Wonderful, thank you. Good morning, good afternoon, good evening to everyone. We're so glad you've been able to join our satellite session, Implementation Science Field Building Collaboratives in Global Health. And we're about to start session 1. This event is brought to you by the Implementation Science Collaborative, and we're really excited to have you all here today. So our first discussion will be on the changing landscape of global health implementation science collaboratives. And I will pass it over to our co-chairs. We ask that you remain muted and off camera. And if you have a question, please feel free to share it in the chat. Thank you.
Yes, good morning. I'm Neil Brandis with USAID. I'm the AOR of the HERD Project and also Chief of the Division of Research and Policy in the Office of Maternal Child Health Nutrition. I'm really pleased to sort of launch this discussion along with Dean Bertossi. And specifically, one of the things which I'm struck by as we go into this is that the Biden administration has highlighted a number of priorities which very much resonate with what this group has been working on. Among them, they include looking at issues of operational effectiveness, or what some people would call adaptive management of learning while you go, while looking for long-term impact at the same time, supporting countries in their journeys to resilience, working on issues diversity, equity, inclusion, accessibility, and very much focused on locally led development, which has been a signature of HERD and the ISC in really trying to sort of move forward on. And finally, the whole issue of partnership for sustainability. So the format for this session is very much an interaction among the speakers and really grappling with the successes of the projects, but also some of the ongoing challenges that all of these colleagues have faced. So with that, I want to turn over to Steph Bertossi to sort of launch us further. Over to you, sir.
Thanks, Neil. I'm Steph Bertozzi, and I'm on the faculty at the UC Berkeley School of Public Health, and it's my great pleasure to welcome our extraordinary panel to this session. I'm thrilled to see old friends and some new ones here today. And rather than my trying to do any of them justice by introducing them, I'm going to go around my Zoom screen and ask everyone to introduce themselves. So why don't we start with Janine. Janine Kondo from CIIC, HIN, and the universities of Rwanda and Tulane.
Thank you so much, Steph. And it's actually my pleasure and honor to be here with you. I'm Janine Kondo. I work as associate professor at the School of Public Health, University of Rwanda and Tulane University. I'm recently the CEO of the CUGH, which is an organization that is helping to bridge actually the gap between the policymakers, funders, and academicians. Over to you. Thank you.
Thanks, Janine. Danielle from GFF/World Bank.
Thank you, Steph. Hi, everyone. I'm Danielle Charlotte. I'm an implementation research and evaluation specialist with the GFF, focusing on our results team and our new implementation research and evaluation strategy. Thanks.
Thanks, Danielle. And now Peter Weiswa from Makerere.
Thank you, Steph. My name is Peter Weiswa. I am an associate professor at Makerere University, also visiting research at Karolinska, actually, which I'm visiting right now in Sweden. Thank you so much.
Thanks, Peter. I didn't realize you were in the land of long summers and short winters right now. So next, why don't we go to Rachel Freeman at Mount Sinai.
Hello, my name is Rachel Freeman. I'm the chair of the Department of Global Health at the Icahn School of Medicine at Mount Sinai and the director of our Arnhold Institute for Global Health. I'm a pediatrician and health services researcher, and most of my work for the last 20 years has taken place in the AMPATH collaboration in Western Kenya.
Thanks, Rachel. Next to Mary Sando from the African Association of Public Health.
Hi, and thank you very much. It's a pleasure to be here. I'm Mary Monica Sando. I'm a medical doctor and a public health specialist, and I work with the Africa Academy for Public Health in this and for the years. I've been extensively involved in evaluation studies, in particular implementation science, with a focus around maternal newborn child and recently adolescent health and nutrition. Pleasure to be here. Thank you.
Thanks. And last but not least, Jim Sherry, who's kind of my boss in this space. So Jim, why don't you introduce yourself and then say just 2 words about how we ended up where we are.
Well, sure. I'm Jim Sherry. I'm not Steph's boss. Never have been. Never will be. I am the director of the HERD project as a part of my day job, which is a professor of health policy and management, director of the Center for Immigrant, Refugee, and Global Health at the City University of New York. I wasn't prepared to actually say how we got to this mess. We are where we are, but I let me provoke out a few questions. I was thinking I'd direct them to Peter, just as because maybe we've known each other the longest. Just as we're looking at the context of our current world and in the pandemic and all that we should be learning from it and should have learned before, I just want us to kind of look back a little bit and think about, okay, where we've come from. So in terms of, if we go past our Second World War, more modern organization in international health, we've kind of migrated slowly from a kind of post-colonial control and command operation, if you will. And then with the good work and good leadership of people like the Rockefeller Foundation and getting more collaborative approaches, such as in the neglected tropical diseases and England and the Green Revolution and the evolution of how the family planning areas moved or forward in that same area, evolving out to things like the Partners in Population Development, the kind of more collaborative approaches that have come out of the UN system post kind of control and command, which has been, the entities more like the UNAIDS and the children's vaccines initiatives that have evolved to the Gavis, or the health data collaboratives evolving out of WHO into much more collaborative activities and the ARISE networks and all of the many things that are going out there. So I wonder if we have moved from control and command towards collaborative. I mean, somehow you have to deal with the anarchy out there. But, and so my question, I'm going to pose right to Peter as we pass this along. One, are we still north and south in all of this? Or two, are we progressing in our learning from each other a little bit more? And then finally, is implementation science and the collaboration around it, is that helping us progress from this false dichotomy of knowers and doers? Are we somehow getting more of a bridge between knowing doers in that process? So with that, I'll pass the baton to Peter.
Thank you so much, Jim. It's an interesting question. I think in general, there is some progress, and right now there's a lot of effort to make sure that it is led from the south, but still many times designed from the north and funded from the north. And I think that is where the progress is, but also what is curtailing the progress, because you have to ask the question that, is implementation research known? Yes, it is getting to be known, but I should say many schools do not yet teach it properly, and therefore it is just getting to be known. So more needs to be done to get the locals to become experts in it, but also know its value. We currently, I think we have a couple of efforts which are more intentional. I mean, moving from more random projects. I mean, a colleague in the north say, I have money, or there's this grant, we go for it, to more of intentional collaboration. And I think the GFF is one area that is trying to embed, and Uganda has been a leader of that, to embed implementation research. Of course, the HARD project too, but also we've done work in Uganda with Gavi in what we call a prospective country evaluation, which was more of IR and also with the Global Fund. So there are efforts. But for me, what puzzles me until now is that they are not necessarily government-led. And that is, for me, the challenge. So we've had a lot of very successful, reasonably large, but not at scale projects. In Uganda, I can mention like the Saving Mothers, Giving Life, which was in Uganda and Zambia. I was PI for it. And with the maternal mortality reduction of over 40% in Uganda and also Zambia. But for me, the question is always, if we have such a successful endeavor, why do countries and partners continue looking for other solutions? Why don't they then just get it scale? So for me, one of the issues is how do we design implementation research so that it achieves the objectives of the day, which is for me scale, equitable, and impact. For me, that is quite important because it aligns very well with the SDGs. So it is no longer so much of North control. It is evolving, but I think more needs to be done, especially one has to ask the question, what is the role of government in these issues? Can the government start taking lead in this work? In many places, they say the university or a partner that is leading, and I think there lies to the challenge. Sometimes we've applied for grants and we ask the government, can you embed implementation research in an application to the Global Fund? And like the government doesn't want to do it because they think universities have money. But it would be good that if we co-design with government and then co-implement and then become more accountable. I think that is what I can say as of now. Thank you.
Thanks, Peter. Janine, when I think about all of the people on this call and beyond who are trying to build capacity and implementation science and research, it occurs to me that epidemiology is pretty much the same two courses all over the world. Implementation science is a lot harder. From your perspective in Rwanda, sort of having worn your implementer hat and back and forth to your academic hat, how do you see this this need for capacity building, what Peter was mentioning, because Peter mentioned that there isn't a lot of training happening in Uganda. The truth is there's not a lot of training happening in the United States either, because this is a new area for both Uganda and the United States, and certainly new in terms of curriculum for public health students. So give us your perspective from Rwanda, if you would, Janine.
Thank you so much. Steph, I think what we are discussing today is really, really important. I think I will look at this at different level. First level is, what are we dealing with today? What are the problems that we're dealing with in terms of implementation science? And then what are we doing for our future generation, our students? What are we teaching them? I think today there's, we just finished a working group on health system evaluations with ITAD, where we found actually there is, even within a country, stop looking at North and South. Within a country, you have academicians, they have the way of thinking about research. And most of the time, they don't consult with the policymakers to bring in the ideas and issues and challenges and gaps into the research. And at the same time, when you see that power between the founder who has the money and the research, or researchers within the country, is more tighter than founders and the policymakers. So I think we need to work around that. And something that we're trying to do at CUGH is actually, we don't look at the founder yet. So I'm glad that Daniela is here. We work with Peter Hansen from JFF. We go to the data. So there's plenty of data that we learned from COVID that first start using the data, and we can help as academicians, policymakers, to use their own data. So what we do, we speak with policymakers. What is bothering you? What is the problem that you're having? And then we take that, we go check and evidence-based with the data, HMIs, EMI, there's a lot of data that is there. By doing so, we also doing data mining. So we get actually graphs, like recently we found that actually vaccination coverage has gone down just using HMIs. Then we pick that data. We go back to GFF or agency funds. Here, this is what you're doing. This is what we are funding. How can you help? And we design intervention around the needs of the policymakers that are, okay, for example, the case that we found is the vaccination ANC went down. So what we did, we wrote a proposal around ANC, and something that we are now planning with agency fund is to use Mom Connect as an intervention, digital health intervention that can be adapted within the country context. By doing so, we are not only listening to where the funding is, but listening first to the policymakers. They don't have time. They will never have time. Even if you teach them, you give them capacity building, they will never have time. So on the side of a future, I think the level 2 that we talked about is what are we teaching our students? If these guys are going to be the founders, these guys are going to be the donors. What do we do now? If I'm a Gate Foundation, I'm a Global Fund of Gavi. I've been sitting in TERG, Technical Evaluation Review Group at Global Fund, also at EAC as Gavi. What we found actually, donors come with ideas that this is what I think the country should do. How many of the donors actually are using the concept notes, the objective, the issues from the country perspective and build it into RFP? So I'll pause here, and I think it's a call for all of us to see where we want to be as academicians, as researchers, as policymakers. Thank you so much, Steph.
If I could follow up there for a moment, Steph, with maybe the group. You know, when we started work on implementation science, and certainly looking at the leadership of many of the people on this call, the reaction from policymakers was the research is too slow and too expensive. So I'd love to hear from all of you, how far have we progressed and how do we respond to that question?
So maybe Rachel, you want to take that one first?
Starting with an easy question there, no, that I think it's a terrific question. You know, as someone who is at the same time, you know, in academics and wants to do good research, of course, as everyone on the call, and at the same time, as a clinician, as someone working in health systems where, you know, the needs are often rapidly moving and, you know, even more in evidence as we've moved through this most recent pandemic or moving through conflict periods and other things where we have urgent needs. I think it's a constant it's a constant challenge, certainly. And I think Dr. Kondu brings up such critical points in terms of where, you know, if funding has very targeted, you know, goals in these ways, and when there is you know, when there are tighter restrictions around it, how it can be very difficult in that sense as well to be responsive to local needs, and how do we move that forward? You know, this is certainly not saying that I would be remiss to say that we've moved forward in dramatic ways in being able to address that challenge. But I can speak from the experience of the partnerships that I'm most familiar with, and I'll particularly speak from our experience in Kenya and the Empath partnership, and that's a model of partnership that the Arnhold Institute that I lead, that we've tried to replicate in some other places. One thing I think we've tried to do together to address this challenge and the balance of having more equitable, sustainable work moving forward is to align partners in a balanced way, and by that I mean we've tried to bring together both academic partners, and in this specific Kenya example, as one example of this, for example, Moi University and the School of Medicine in Western Kenya with a consortium of North American universities. And then also, though, to align the health system with which they're engaged, the Ministry of Health as a strong government partner, and to try to figure out if we can, together with government, with health system, with academic partners, find a better balance in terms of what the spectrum of what the local priorities are, how we can best start from the immediate context and the specifics in this way, do good academic work, and yet see much more immediate impact in terms of how the health system becomes aligned around any evidence produced. And then ideally, the first challenge that is being discussed in terms of how that evidence might move into broader scale at a national level or even beyond. And I think my only, through lots of trial and error and years of partnership around this, I would say the times when we have done this best together have been when we are together, when we are really from the first moment we're trying to address, an emerging outbreak or a new conflict in the area, or some of those most time challenged things, has been when we are able to be together fully together with our local partners, whichever side we are on of the ocean or anywhere else, equator wise, north, south, etc., that we're together from the very beginning in it, that we're focusing on the very specific clinical challenge, typically, or care issue that we're trying to address, and then thinking together where the infrastructure we've created over these years can be most quickly applied. And that's where I think having, our longer term emphasis on building up strong data systems, ongoing monitoring and evaluation, really building capacity over the long term, can then be brought to bear to make things more efficient in that. I don't know, as again, one example of that, but I've seen that work in times of both conflict and in some of our most recent pandemic challenges. But I think it's because we're aligned on a long-term framework of collaboration, of infrastructure, and of wanting to reach that place where we can respond together on the basis of, long-term relationships and institutional relationships in that way together.
Thank you so much, Rachel. Mary, I'd be really interested in your perspective. Do you see that implementation science is starting to become kind of a full partner in public health? What's your perspective from AAPH, and how is it being incorporated into your work?
Thank you, Steph. Yes, I definitely see. I think maybe this is a good follow-up to your previous question, just very well answered. Initially, definitely, it was slow, but maybe if I can speak from at least two examples, which I have been involved in, which I think most people here are very familiar with, is through the HEAD project, the Implementation Science Collaborative, where our partners, the Africa Academy for Public Health, was to work with the stakeholders, particularly try at every moment to bring together the policymakers, where we really were hoping to see that homegrown evidence through two implementation science projects, 3 particularly in the region of Port Council, Kenya, can really come to a point that would advance into policy, would advance into our practice and the way we do things, with the ultimate goal of really providing the best and the most ultimate quality of care when women come for antenatal clinic during delivery and postpartum. So it's been evolving, it's been exciting, it's been a process where at some point we've had to be very patient. So I can say if there are lessons that I have learned is, I think, one, consistency, ensuring there is stakeholder involvement, and stakeholders in this sense, I mean, even when we were designing the research back then here in Dar es Salaam, I believe even colleagues in Ifakara who worked in their project in the semi-urban area in Tanga, we involved the Ministry of Health. So that's one key stakeholder, who is the one that would take further findings and bring stakeholders together and ensure that they eventually have guidelines that will provide directives and guide healthcare providers on how best we can approach general practice into being able to include in it emphasis and eventually enact that culture change so that women can, enjoy the care much better in a more respectful and dignified manner. So over the years, something that was anecdotal became a practice with repeated involvement of the stakeholders. But what we wanted was really to make sure that that evidence that came through an implementation science project with multiple other partners working, very strong support from the USAID, really would have that driving seat of our government. So I think one of the key things have to bring the stakeholders together, and these stakeholders are multi-faced. Particularly for us, I could say one success was to ensure that the facility that we did our research was very much on board. And therefore, it was easy for them to accept the results, which were not good results. The results that say that that facility in particular was mistreating women when they come for delivery. At about 15%, women were unhappy. They were slapped. They were, not treated very well in those 7 dimensions of disrespect and abused. And they were, not treated in confidentiality. They were not informed about the service they were going to receive. And later on, up to 70% of women reported the same disrespect and abuse when they went home and when we followed them 4 to 6 weeks later. And therefore, the positivity of the response was among the key drivers of change for us from that particular facility, because they accepted that there is a problem. They were part and parcel of the process of finding this prevalence of disrespect and abuse, and they were part and parcel of designing the project or interventions which we tried. And therefore, although initially we really wanted, for instance, to try and do a companionship program, which later on was done very successfully, and I think is among those that through Saminio High are really being considered also a great success. It was very difficult for us in the very early stages, even for the government and the other stakeholders, to think that it would ever be possible to have a companion of choice for a woman coming to deliver in a public health facility within our settings. And therefore, it's exciting to see that once you're able to ensure that the scientific evidence becomes palatable, it's easy to be understood by policymakers, and they feel definitely we need to make sure our whole management in the ministry understands that this is a problem, and we have to come together and find a solution. And then eventually having several meetings over time with, again, different partners working together, our government was able to actually roll out its first guideline, develop and roll out its first guideline for improvement of a more respectful and dignified care for women. And now it's exciting to see that it's going beyond just services that women receive at antenatal labor and delivery, because just yesterday, the chief medical officer would speak about they're putting systems in place to make sure that our clients, when they come to health facilities or if they receive outreach services in one way or another, they can communicate their experiences. And ideally, in many cases, is when they're very unhappy or they're unhappy. And therefore, he's saying we're putting all these in place so that we can learn from our clients. These are they're the reasons why we wake up as the health sector to get to do our work every day. And we hear that every now and then. And therefore, personally, as an implementation science member of this team, I'm very excited to see that things are really developing. And not only that, we now are at a point where the ministry wants to see if we can be able to actually measure ourselves. Yes, we have a guideline. Have we been able to roll it out well? There are gaps there. What can we do? And so I personally am very grateful to have had the opportunity through the HUD project to be able to always bring stakeholders together. But the key thing there, I can say, is to make sure that the driving seat of this agenda, with all our support, was done by the government. And so it was through that whole process of implementation science, translating the evidence, being patient in the process, that the government took up this whole whole activity and was able to launch these guidelines. Similarly, through the Africa Academy for Public Health in very close collaboration, we jointly launched the Africa Research and Implementation Science and Education Network, ARISE Network, which currently has 9 member states, nine member countries, but within those countries, there are 25 participating institutions. And therefore, definitely starting with, just an idea, we already are at a point whereby the past 3-4 years, we have been able to identify our theme of focus, and that is on adolescent health issues. And therefore, you can see that collaboration and partnership embedded for advancing implementation science can probably, I can see it can take us even much further, where we can come up with questions that we can learn from here in Tanzania, in Ethiopia, in Uganda, Botswana, South Africa, and Nigeria, all at the same time. And therefore, it's exciting that with collaboration and partnership involving the different stakeholders together, we can be able to use implementation science and be able to answer so many questions, which ideally would probably have taken much longer if each partner was working in silo, than when we are able to get a much bigger picture because we have similar challenges across the sub-Saharan Africa. And therefore, we're looking forward to even much more exciting opportunities of working together through the space, looking at adolescent health, but we're also looking at possibly coming up with looking at a follow-up for antenatal and postnatal women. We believe there can be, and in most of these countries, we are trying our best to nest ourselves within existing cohorts where we can be able to tap over time with, the follow-ups and probably bring even much bigger lessons over time. I'll stop here for now. Thank you.
Thanks, Mary. If there's a website for ARISE that you could paste into the chat for people to look further, that would be great. Okay. Danielle, earlier, Janine, not directly threw out some challenges to donors, but indirectly did. And so I wonder if you'd comment from the perspective of an important new donor. And while you do that, there's also a question from Rosie Gowron in the chat, which is asking about the degree to which funding goes beyond the initial implementation evaluation and to sustainability, and what the GFF's perspective is on that. I could also ask Neil, because of course, at least in the area I know best, which is the PEPFAR area, it certainly has gone into the attempts at substantial sustainability. So Danielle, over to you. What's your perspective on that?
Thanks, Steph. Yeah, everybody has touched on elements that we are grappling with right now. And the question in the chat also speaks to that. So as I mentioned at the beginning, we're developing a new implementation research and evaluation strategy. This effort includes both sort of process-related learning. So for example, how does the GFF more effectively support, routine data for decision-making? And it also focuses on sort of thematic focused learning. So for example, adolescent health is an area of interest for the GFF. But really the foundational element underlying all of this is country leadership and strengthening partner alignment to support country-led processes. This is a core element of the overall GFF strategy, and we're really leaning into this for the implementation research and evaluation strategy. How this gets operationalized, of course, will vary by country. And again, falling in that line of like the country leadership, we really need that guidance from country in terms of what support is needed. How does the GFF, from the Secretariat standpoint, how do we best support that? And how do we best sort of help with that alignment agenda, bringing partners together to do that? But we're very eager to learn from these different experiences in countries and use that to continue tailoring and sort of adapting the process going forward. I think the other element about, a couple of people have mentioned about linking sort of the discussion about research priorities with implementation and policymaker priorities is also a key element for us that we've been thinking about and talking about. Particularly in global health, research is done, or at least should be done, with the goal of contributing to countries' health and development goals. And so with that in mind, we need to not just connect stakeholders and make sure they're all in the dialogue, but we really need to go a step further to prioritize implementer and policymaker viewpoints and their voices in determining research priorities. To me, a key to this is really understanding how research findings are being used and identifying those pathways and processes for early dialogue about research priorities and then eventual uptake of the priorities. So I think we all know very well that that's not a linear process. It's not like, here's the question, who's going to answer it, how are they going to use it? It's a much more complex process. There's a much bigger system for that. But there needs to be a bit more of a concerted effort to understand what the levers and barriers are within that system. What are the dynamics that we need to be aware of? And that's something that's typically not very well funded in research. So from the GFF perspective, that's something we're grappling with, is how do we actually fund and or contribute funding to that type of activity? We need to give enough time and enough funding to sort of lay the foundation and planning for this work, as well as for intentional engagement with these pathways or processes along the way. It's certainly something that I don't have a great specific answer to the question in the chat, because it is something that we're grappling with now. But really trying to think through systematically, where can we use DFF fund to catalyze momentum in a certain area, and then, or certain areas, and then where could we also put country leadership sort of in the driver's seat of the research priorities. And from the Secretariat standpoint, how do we support the development of country leadership to defining research priorities and funding research from the country level, rather than it being very externally driven. So I'm very happy to get input from all my colleagues on the phone and to continue discussing, because it's something that it's a very active discussion right now about how to move forward with that.
Something that just occurs to me hearing you is that there are lots of things that donors do, whether the payer is a government or a multilateral bank or a development agency. But one thing that I think has been a really positive development over the past 10 years especially has been donors that have as a condition of their funding obliged data transparency. And whether that's the NIH in the research world or agencies funding in the implementation space, where having implementation related data enables people to learn from other implementations and fosters this spread of research. I'm curious, maybe going back to the top of our discussion, Peter, how do you see that the issue of data and implementation science and potentially the appropriate or inappropriate roles of donors in ensuring that those data are as transparently available as possible?
And if I could add one gentle, friendly amendment, is I'd push it one step further and ask, to what extent are we still hostage to journal submissions? So one of the tensions in this world is who owns the data? You can't release the data until the journal allows you to, or is it the government's data to implement?
Peter, you're muted.
Sure.
So like if I can talk about Uganda, there is a new law on data ownership. And the law basically says it is the person from whom you collect the data that owns the data. And the government is a guardian of that. But in the reality, I can say unintentionally we are all abusing it, because with the scientists, the journals, the donors really take the data, and there are several ways of getting the data. I always say the way defined parties get the DHIS2 data from Uganda, even when they put passwords, people always find a way around it. So I think this is an area that needs to be discussed a little bit more so that there is more transparency. Having said that, the government also needs to improve to make sure that data is accessible, because sometimes it's just so difficult to get the data. I mean, during this time of COVID, we've been struggling to get data, actually to sometimes advise government. I'm a member of the NITAG, Independent Technical Advisory Group on Immunization, and we have a committee on COVAX or COVID. But sometimes we want the data so that we can use it to guide local decision making. But it can be problematic going through so many steps to get the data. So I think it's an area that requires more dialogue to make the data more available, accessible. But also, I think this challenge, which we need to address, as you said, Neil, of journals, because journals want to grab the data. And I think there's a problem with us scientists. When we want to write a paper, we only have one purpose, to get the paper published, and you would do anything to make things that the journal wants. The journal becomes king. But I think this is an area that needs to be changed. I would give one example. Over many years, we did saving mothers giving life, but actually the data is just being available almost 10 years later. And I've been invited to meetings to analyze that data. I'm with a lot of discomfort whether I should go to those meetings because the data was so important. The data talks about maternal death, neonatal death. These are very unique, and we had data at population level. So I think this is an area I'll not mention which organization because it's a bit sensitive, but I think it's an area that we need to be engaging with a little bit more. Why would you hold on data that potentially can actually help make a decision and save a life or save lives? So I think the scientists, the government, the donors, the journals, all of them need to come to a round table and we discuss this. I think data needs to be, if it's collected in the country, then clearly it should be defined how it is going to be used and made accessible. And if people are going to use it for other purposes, then it is made clearer. Thank you.
Thanks, Peter. I want to turn to Janine, but I think that the academics need to also accept responsibility because, Neil, you nicely deflected it to the journals, but now that almost every journal of any prestige will accept manuscripts that have been previously posted on preprint servers, I don't think we can blame the journals anymore for that secrecy. That's I think past. And I think what still remains is when researchers hold on to data because they can mine that data for the next 10 years and that data are not made available. Janine, sort of continuing on what Peter said, I'm interested whether you see a difference between the more clinical data, the more effectiveness data that Peter was talking about, and implementation science data with respect to, how best to implement programs, how can programs be more efficient or effective. There's so many lessons that can be learned or that could be learned if we had better access to implementation data. How do you see that?
Thank you so much, Steph. I think what Peter said, we all came to learn the hard way with COVID. It's the first time that we see a lot of data. I don't know if you know the website Worldometer, where you have all countries simultaneously in every single second to know what are the cases, mortality, morbidity, and so forth. So I think with COVID, we came to understand, especially here in Rwanda, that putting data there, especially not exposing individual ID, protecting them, was something that was really great, where policy decisions are happening right there during what Peter in Rwanda we call SAG, which is Scientific Advisory Group for COVID. And something also that we learn is not only academicians, research, we are seeing a lot of partners. We even see involvement, for example, BMGF in those SAG meetings, where you see there's no boundaries between global, south, north, and so forth. But we see more partnership, we see more implementation sense, we see more policymaker taking decisions based on the evidence because everything has been now open. So I think also, Steph, you said something very important on the preprint, something that the initiative that you're bringing in, I think also that boosted a lot the papers and the visibility from the source where data is actually sitting. I think we are looking at that at different levels, level for protecting the patient or the clinical data that we are collecting, where we put the data there, but making sure that the IDs, everything is being protected for, so that researchers can use the data. But at the same time, who holds the data, who holds the final decision for those papers to get out? I think there's a lot of dynamics that we all need to work around to push, especially the Global South Express, and use their own data. I teach the conversation of global health at UCSF. I think this is something that is coming up with, if you just take any data from COVID and comparing where the data is coming from and how many authors are on that paper, you see a lot of discrepancy. And I think with this initiative that Steph has brought up, I think on the preprint, I think is really, really helping. And you see a lot of papers from the South coming up and helping back the decision. So decisions are no longer taken or delayed just because the data is being held somewhere. I don't know if I respond to the question, but I think
Stephanie, I'm wondering if there's another culprit here, which is capacity. We seem always to be a step behind in the capacity we're building. And again, we can look backwards on that and see that, post smallpox, we weren't really ready to take on the child mortality goals. And then when the infrastructure that developed there wasn't really adequate to deal with the AIDS epidemic. And so there are all of the adaptations that happened. And now, we're confronted with COVID. And again, we're caught unawares to some extent, we appreciate at one level that there needs to be a very strong collaboration between the science community in country and its government, in terms of how to address things. We also appreciate that the science community in one country is very connected to the science communities in other countries, as are governments connected to each other. And I wonder this time, we've kind of failed the pressure test here, at some level. And I wonder if we looked forward and we all had a magic wand, what we might project from ourselves, or what are the capacities that we would like to see in the future that would have helped us navigate the space in the past. I'm not sure our international collaborations were always helpful to us in terms of, as scientists to science, helping government to government in that process. So I'd like to hear from others what their thought is there.
Yeah, Mary, do you want to perhaps take on about a bit of what Jim was asking there? I think one of the things, just while you think about that for 1 second, Monica brings up the fact that we need real-time evidence and data for implementation science. For me, that's been a fascinating thing about COVID. I've been involved in a number of collaborations to help real-time analyze COVID data, but it took us 6 to 18 months to get access to the data so that we could do real-time data analysis to inform the response, which of course was then far too late. Maybe one of the good things about what COVID has done to us is to make us recognize that for those things that need real-time decision-making, like implementation and rapidly spreading infectious diseases, we need to think in advance about how the data system can provide those data in a real-time way. And even more importantly, perhaps, how those of us who are academics can actually be responsive on a time scale that is relevant for the people who are implementing. So Mary, I'm curious to know your take on that.
Great, thanks. So I think not different. I think we're dwelling on COVID's situation globally as an example. Here in Tanzania, I think you would all be familiar how difficult it was with just accepting that we have COVID, 1, and then 2, the data being so protective, even though testing was being done, but it was very, very high level communication. And therefore, though things have changed, we are now, like the rest of the world, sharing our testing data, but also vaccinations are ongoing. Similar to Peter, I'm also a member of the NITAG here in Tanzania. And even recently when we had our meeting, we're still struggling. And one of the things that we have been trying is to request for data that, just as you said, not to repeat, can help us better advise the government, because it's an independent group. And so our job is to really advise in terms of vaccination and immunization. And of course, now has really been on COVID. Of course, there's also been risks of polio and all that. So definitely it has been a challenge for us here in Tanzania. I think back in 2015, our government created and formalized a Statistic Act that made things even much more difficult. In a way, has had its own and still has its own pros and cons. It's important to ensure that local researchers are also protected. They are also part of the publications or of the evidence, because they have worked together jointly, either locally or with international partners, and therefore that led to creating a system whereby, one, there has to be insurance of protection and safety, one, of the identification, but also ensuring that which is being published, whoever is leading as the PI and the study team are really responsible. And whenever you have an international collaborator, you also have to have a Tanzanian collaborator who is also working or is affiliated to a government institution. So this became very difficult initially because it took time to translate into what practically that means. But now we are, we're used to it, and we know when we write proposals, we always have to also identify and welcome another researcher who is, affiliated to a public institution. But I would say generally, there has to be there has to be, I think, a common goal whereby, just as today I'm excited, I was in the morning in a meeting that was for the first time called by our National Institute for Medical Research. And the idea was really to look into tons of data, lots of research, maybe some repetition, but what are we really learning from this data, and how is it really helping us with shaping our policy and practice in the country? And therefore it was exciting for all of us who are working in the space of research to be invited by the National Institute for Medical Research custodian for permitting research implementation and providing all the ethical guidelines, to say, guys, we need to come together and see how best we can expand, maybe improve on our research data and all repositories for different health related data and research findings being done here in Tanzania. And beyond that, how can we now, it's actually supported by PEPFAR, probably they help them think through and be able to look at not only around HIV, but across the whole spectrum of health and health research. And therefore, I see that as a great stepping stone for us, or a starting point. Last year, AAPH, in collaboration with the Ministry of Health the ministry responsible for implementation of all works that's working directly under the President's office, together with the Ministry of Health, we had done an implementation science activity for nutrition. It was a USAID, it's an ongoing USAID funded project under Save the Children. And our task there was to do a baseline survey, but also come up with an operational training manual and train the council officials so that they can be able to have an appetite, get a better understanding, to start doing research, understanding their data, and wanting to actually use it to understand why within Tanzania's health baskets, there is still such a huge challenge of, for instance, high prevalences of stunting and other nutrition-related disorders. And therefore, we looked everywhere. We couldn't find a manual that's useful, that can be a straightforward one that we could have, modeled or something to use. And therefore, we had to start from scratch, building an operational research manual that can be used for training this cadre within the councils, so that they can start to focus more and do more in understanding the data around nutrition and wanting to understand gaps by coming up with their own research questions. And therefore, we realized there's such a huge gap within the council level. There's this huge.
Yeah, Mary,
Yeah.
I wonder if we could do a rapid fire round on one of the questions in the chat box, which is one, many of you have been leaders in the AIDS community at different times. And the question is really around what is the role of NGOs and the advocacy community within the space of implementation science and research? And so it'd be great to sort of hear from all of you very quickly, what role should they play or what role are they playing currently?
Just a thought, because we have 30 seconds each, as we're at the almost at the top of the hour. So Rachel, do you want to?
Oh, I let somebody else take it. Thanks.
Sure, if we're going to answer that way, you know, I think there's, I was thinking in terms of the previous conversation that the role of dissemination can really, for those of us who are in academics, I think we also need to really think about what it looks like to push both capacity in terms of our skills with doing it, but also the ways in which our work collectively gets counted for broader types of dissemination, that we do absolutely need to think about how information can move to communities in forms that are appropriate for community partners, and we need to push our institutions collectively to make that an acceptable type of output. And I actually think that's a role for NGOs as well, to connect with those critical partners and to look therefore around how we can best disseminate and then evaluate that strategy.
Great, thanks. Janine, quick thought?
I wanted just to add on what Rachel said on, I think the role of NGO should to reinstall the trust within the government leadership. I think we see that mistrust a lot. I think the trust, we need to make sure that we have a space for them to maneuver any strategy that we can do. I think also, and as Daniela said, there's nothing that can happen if we don't have the leadership. I think so continuous leadership in a way that is not a training, but doing and applying leadership skills in what we do, I think will make a difference. Over.
Great, thanks. Danielle, quick thought?
I mean, I think they're very important partners in terms of driving demand for generation of certain types of evidence, and then also linking back to communities for uptake of it. I think, Mary's example related to respectful maternity care, I think is a clear example of that, that it sort of raised the profile of this as an important topic to women and to people in communities.
Great. Mary, do you want to have a quick thought in response?
Well, I think I echo everything that has already been said, but I think one is to look into what can be areas that, considering the very evolving sometimes positions within the government, but having NGOs helping the government to advance a particular agenda around research, because there can be consistency, jointly applying for grants together, but really following where the gaps are, being able to bridge between the evidence and how best to reach that into policy. I think would be a part that, like the way we were able to support in our own way through the HEAD project, to make sure that agenda was consistent despite the change of leadership over time within our government. I think that's one of the roles we can play.
Yeah, the Academy as well. Jim, please, quick thought.
I think we need trusted voices when we're into problems. And I think we saw a lot of talking science heads, and scientists were all trapped by the nuance of elements. So it's hard for us to just say something the way an advocate would say it. And to have advocates who are trusted voices, who are working closely with the science community, who are putting demands on the science community for the evidence that they need to be able to speak plainly and clearly to the general public. I think that needs to be a more organic partnership, not just getting their inputs, but actually respecting and promoting their role as a voice out there, a trusted voice that can make a difference.
And Peter, to bring us home, last thoughts on the partnership with NGOs and advocates.
Thank you so much. I think many programs now around NGO.
Peter, try speaking up a little bit louder. We're having trouble hearing you.
I think can you hear me now?
Yep, good.
So I wanted to say that many programs in our countries and some programs are only done by NGOs. So they need to know IR, they need to do IR, they need to document it well, disseminate it, and sometimes fund it, and demand for it. Thank you.
Neil, you're our patron. Would you like to close us out?
I wouldn't consider myself the patron, but this has been a really stimulating hour, and I really want to thank all of the speakers and the participants in really sort of helping us to think about this issue. There are a lot of things this group should be really quite proud of its achievements, but also a pretty hefty load to really keep taking this forward. There's still much to be done. So thanks to all for the session, and please join the next session shortly. Over to the HERD team for any details.
Great. And Neil, thank you for all your support over this whole long project. Thanks to all the participants. Super grateful for a really great session. Bye, everyone.
Thank you. Bye-bye.
Good morning, good afternoon, and welcome to session 2, Enhancing Uptake of Evidence-Based Maternal and Mental Health Psychosocial Support Interventions. We're really happy to have you join us today. This event is brought to you by the Implementation Science Collaborative. We ask that you kindly stay on mute and keep your cameras off. And if you have a question, put it in the chat. So without further ado, I will pass it over to our co-host, Dr. Vicki Ngo.
Hello, everybody. Good afternoon, good morning, and good evening to all of you. Thank you for joining us in session 2 of our roundtable discussion on Implementation Science Collaborative and Global Health. This is the second session and it's focused on enhancing uptake of evidence-based maternal and mental health psychosocial support interventions. I'm Vicki Ngo, and I'm Associate Professor here at the CUNY School of Public Health. I also direct the Center for Innovation in Mental Health, and we serve as the global anchor for Implementation Science Collaborative, focused on the mental health psychosocial support portfolio. I'm co-chairing this session with Dr. Dallas Walker, who's an associate professor in the Department of Obstetrics, Gynecology, and Reproductive Science at UCSF, who leads the Maternal Health Collaborative. And we are very grateful for the funding that USAID has provided to support the HERD work and the formation of the partnerships in our 5 key priority areas, including women-centered care, maternal health, mental health and psychosocial support, violence against children, urban health, and assistive technologies. We're excited to move this work forward through the Implementation Science Collaborative, which will serve as collaborators to advance the evidence to practice priorities in low and middle income countries, and look forward to facilitating greater integration across the maternal health and maternal and mental health collaboratives. Over the course of this year, we all have been affected by the rise in mental health concerns and challenges, which prior to COVID was already a significant public health concern. In the aftermath of COVID, mental health rates have doubled and tripled in many places around the world. Through the work that we support in the Mental Health Psychosocial Support Learning Collaborative, we've seen the development of new models of care that involve task sharing of mental health promotion, and various service tasks, development of psychosocial programs that are delivered by a variety of different community providers, including leaders and staff and primary care. We've also seen opportunities to further integrate mental health into a variety of different settings, including maternal health, which we see as a priority area. And we hope that the discussion we have today will provide us with additional insights from leaders in the field regarding where they see the opportunities for integration, as well as where implementation science and collaborative partnerships can help bridge the gap between mental health and maternal health. We hope to leverage existing work in these 2 areas to further develop and support this integration and advance these 2 bodies of research and service systems. The setup for today will be a roundtable discussion that will be about an hour. Will involve 7 speakers, so we won't have too much time to go into details about the research and efforts. What we hope is that we can begin identifying initial findings and direction to contribute to moving the field forward. We'll start with a broad discussion that's going to be focused on global and regional efforts to integrate maternal health and mental health. Following this, we'll invite the 4 panelists who work in this area to share about their insights and lessons learned from their work and opportunities and gaps in the field, and elaborate on how implementation science can move this field forward. Finally, we'll invite Ms. Becca Levine from USAID to share about funding priorities and trends in investment in maternal mental health. After this, Dr. Walker will facilitate a lightning round session that will allow for speakers to share 1 recommendation to move the field forward. And we're looking forward to any comments and questions you might have. Please add them to the chat. And if we have time, we'll make sure to try to address them. With that, let me introduce our first two speakers. Please welcome Dr. Neerja Chowdhury, a technical officer from the WHO and a maternal mental health researcher and psychiatrist, to share about key strategies used to support integration efforts at the global level. Following this, we'll hear from Ms. Rosemary Mosaka from the East, Central, and Southern Africa Health Community, who will speak about regional efforts in Africa. Dr. Chowdhury, please take the floor. Thank you.
Thanks a lot, Victoria, and thank you everyone for listening into this session today. What I'm going to focus on is what are we doing in the global space and what are the opportunities for integration. We know that maternal health is an integral part of maternal and child health. We know that the mother's health impacts the health of the infant. And so integration of maternal mental health into maternal and child health programs is something that what we're all talking about here. This also closely aligns with several global strategies and frameworks. Let me just name a few. First, and not the least, is of course the UN Sustainable Developmental Goals. This is relevant to more than one development goal. We have the global strategy of women, children, and adolescent health, strategies towards ending preventable maternal mortality, and the Every Newborn Action Plan, as well as WHO's own nurturing care framework, and WHO's Mental Health Action Plan, of which the MHGAP guidelines and the MHGAP intervention guide is a part of this initiative. We know that there are interventions that are for prevention as well as treatment of maternal mental health conditions, which are evidence-based. We have tools and resources that can be delivered by non-specialist healthcare providers in order to identify maternal mental health conditions, as well as to provide psychosocial care and referral. This can be done in a stepped care manner. We can have basic psychosocial care and support for all women in the perinatal period, while those who are at risk for depression or anxiety, which are the commonest perinatal mental health conditions, they can be offered more intensive treatments. I've already mentioned the WHO's MHGAP program. We also have the Thinking Healthy Manual, which is in fact a cognitive therapy-based manual for treatment of maternal depression and anxiety, and can be delivered by non-specialist healthcare providers, including peers, including lady health workers who are seeing women and children during the perinatal period. We work closely with our maternal mental health department, as well as with our Department of Maternal and Child Health, to develop tools, resources, and other guidelines that can be used in order to support this integration. Some examples are the Early Child Development Guidelines, which were released last year, that has recommendations for the treatment of maternal depression and anxiety, as well as the soon-to-be-released postnatal care guidelines, which has recommendations for screening for perinatal depression and anxiety, as well as for prevention interventions. These resources are aimed to provide what we heard mentioned earlier, that is sharing of treatment and sharing of different skills that not only specialists can deliver, but non-specialists can deliver, especially in low and middle income countries where there's limited resources. Thanks a lot.
Thank you, Neerja. Please welcome Ms. Rosemary Mosaka.
Thank you very much. Good morning, good afternoon, good evening. So from Extra Health Community, being an intergovernmental regional organization, we take the issues of maternal as well as mental health and psychosocial support very seriously. And I'll just mainly mention the commitment, the strategies, and as well as the policies which are existing at regional and continental levels with regards to mental health and psychosocial support. Though we see that there's a lot of potential to integrate the the two components together, but at least we have started to see that at both levels, through at Continental African Union recently, they have through the African CDC, that we have jointly coming together as a continent, we have developed the non-communicable diseases, as well as the injury and mental health strategy, which we are expecting to launch it in next month, the end of April. So ideally, we came together at continental level to see that it's high time that we should have this direction or the strategic direction with the implementation plan to see how best we can implement the issue of mental health and psychosocial support. At EXA health community level, during our 69th Health Ministers Conference, our health ministers passed a resolution just to see how can we best prioritize the challenges of substance use as well as mental health and psychosocial support in our region. So we had some directive from directing the member states to see how best can we strengthen the human resource capacity for effective provision of mental health services and develop or strengthen the mental health policies and programs to guide service delivery, training, and research. So ideally, when I mention this, it means that the whole aspect in broader terms to see how best can we integrate the aspect of mental health and psychosocial support within the existing programs. And at EXA Secretariat, we were tasked to facilitate the dissemination and scale up effective models as well as best practices for responding to mental ill health as well as substance use. So this cuts across all the age group. And recently we have worked together through the consortium, collaborating with the African CDC, London School of Hygiene, WHO Afro, and WAHO, this is West Africa Health Organization, through the Strengthening Public Mental Health in Africa initiative. This came as an initiative just in response to COVID-19 epidemic, of which we did an assessment to see what are the gaps and how best are our countries faring in terms of integrating the mental health and psychosocial support in emergency preparedness and response. So there are a lot of potentials, and I can say that at continental as well as regional level, there's a call to integrate the aspect in all our interventions. So the strategies are there, the policies we keep on developing as well as integrating through the programs we are implementing. Thank you.
Thank you so much, Rosemary and Nirja. I think what your words highlight is that this topic of mental health and maternal health is certainly on the global radar. There are certainly policies and guidelines that are being built. So that's wonderful that there is a beginning scaffolding. What we're going to turn to now is talk to some of the sort of more researchers, practitioners, as to where are some of these, you said that we're working to scale up of best practices. How much do we know about what best practices are, and what do we need to know about integrating best practices? So we're going to have, two brief speakers from the sort of maternal perspective of this, and two brief speakers from the mental psychosocial perspective. I'll briefly introduce the first two and then pass it off to them. The first will be Dr. Pesha Safulani, who is an assistant professor of epidemiology and biostatistics at the University of California, San Francisco. And she'll be followed by Charlotte Warren, Dr. Charlotte Warren, who is a senior research associate in social and behavioral science research at the Population Council. So I also want to first commend the first two speakers for staying within their 3-minute limit. That was very commendable, and hopefully we'll keep that up with our next two patients. I'll pass it off to you. Welcome.
Thank you, Delis. So I'd like to start off by saying that the first strategy we need to think about is recognizing that maternal mental health is maternal health, and that they are not two different things that we need to be integrating. As researchers, as program implementers with different expertise, we tend to think in these categories and siloed categories. But the woman who presents with a mental health issue while pregnant or who has recently given birth needs to be assessed holistically and not in these lenses that we are viewing them from the point of our expertise. And so I think this means that we are integrating mental health screening, mental health support into our maternal health interventions like prenatal care, postnatal care, just as we screen for anemia, just as we screen for infections when the woman presents for antenatal care. Mental health should be thought of as core to the woman's health and not something separately. I think this also requires that our maternal health providers are trained to be able to do this, to be able to screen and provide basic support and referral, just as they'll do for a preeclampsia. And so beginning to think of this as core to prenatal care, core to postnatal care, I think would be an important strategy in moving this forward. And also from a research and programming perspective, that we need a lot more interdisciplinary research and intervention development teams. So we are thinking of these holistically from the perspective of the woman and not in silos from our perspectives as experts on different topics. Another thing I'd like to highlight is the cyclical relationship between maternal mental health and the things we are interested in now from a maternal health perspective. I do research on respectful maternity care. I like to use that as example. So we know that there are relationships between the extent of person-centered care a woman receives during pregnancy and childbirth and mental health outcomes. There is some research pointing to experience of post-traumatic distress syndrome following traumatic birth experiences. Some of our work has shown relationships between person-centered care received during childbirth and postpartum depression. And so beginning to think about these as core to the woman's experience, that's how we treat a woman, has implications for her mental health, is important for this integration. I think pointing to the fact that when we promote women's emotional and mental well-being by treating them, we can promote their emotional well-being by treating them in ways that are responsive to their needs, ways that are respectful of their needs, and providing care in ways that are compassionate, respectful, and supportive. And also just to mention that mental health has implications on health-seeking behavior. And so women with mental health issues are less likely to present early for prenatal care, postnatal care. And so we need to be thinking about this if we want to emphasize or to address some of the other outcomes. And the final thing is just to highlight implications on provider mental well-being, that we know that providers' mental well-being influences the quality of maternal health care they are providing. We have some work on this going on in Kenya, and it's just been really amazing to hear providers speak to how interventions targeting their psychosocial well-being is impacting their overall outlook on care. And I think Charlotte will speak more to this, so I will stop here and let her pick up from there.
Thanks so much, Patience. Really important information. Charlotte, I'll let you pick it up there.
Hi, everyone. Thanks, Patience. So building on Patience's comments, I'll provide some insight into some work we did through the Advancing Postpartum Hemorrhage Care Partnership with the HERD Project and UCSF in Malawi and Madagascar. And Population Council, through the Breakthrough Research Project, focuses on provider behavior issues. So we know that burnout, mental health and well-being does affect the quality of maternity care delivered by providers, and that burnout occurs at the confluence of economic, professional and social barriers. We know that frontline providers do not always have a voice, are affected by low, irregular salaries, lack of housing and transport, and they don't always feel safe in their workplace and may be disrespected themselves by being single and working young women. They are also absent from any policy dialogue, decision-making, and don't always have the enabling environment to provide the services as they are trained. In Malawi, when we were discussing with stakeholders different ways to address interventions that would support provider behavior change around PPH, the concept of burnout came through very clearly as a problem that providers really do struggle with during it. And this came out during in-country scoping meetings and stakeholder workshops. We use the mass/burnout inventory to measure burnout, which includes scales around emotional exhaustion, depersonalization, and feelings around professional accomplishment and personal achievement. Nearly half of the providers we interviewed said that they felt they were working too hard several times a week, and a quarter reported feeling emotionally drained, out of patience, or burned out from their work, or they felt so tired when they thought about going to work. We also measured depression and PTSD. This was in Malawi only, and we found PTSD more prevalent among clinicians at the hospital level, but also at the lower levels of the health system. And PTSD was strongly associated with both depression and burnout. Increased depression and burnout scores were correlated with reduced respectful maternity care scores. However, when a provider experiences a positive workplace culture and has supportive relationships where the provider is treated with kindness, dignity, and respect, the provider suffers less stress, i.e. supportive relationships with their managers showed improved depression, burnout, and respectful maternity care scores. Elsewhere in Kenya, where we're working on looking at improvements, we saw improvements among providers caring for babies and young children by introducing some simple job aids to help providers identify signs of stress and burnout amongst themselves and their colleagues. We also provided external psychologists and counselors to groups of providers, but also offering one-to-one counseling if required. And one provider indicated that if it had not been for the counselor that came to the facility where she worked, she may have committed suicide. Many providers across the different countries have now realized they are not alone in feeling stressed. Following these simple interventions, we saw improved self-awareness, recognition of sources of stress, and understanding of different mechanisms in managing the stressors. Providers were able to manage stress through reaching out to their peers and friends, praying and speaking out on the actual issues that cause the stress, as well as the improved recognition from their supervisors, helping them feel more supported. So in conclusion, in order to support women through an integrated maternal and mental health interventions, or women-centered care, as patients said, let us make sure that we also give the necessary mental health support to the frontline maternal health providers. Thank you.
Thank you, Charlotte. And thank you both for making it so clear that the provider is a key component of this sort of problem and the solutions that we're going to need to make, particularly as we've been over the years holding our maternal health providers more and more accountable for the quality of care, and throwing additional things on there has to be done very carefully and considering their well-being as well. Now we're going to turn to get a couple of thoughts from the mental psychosocial support side of this equation. And we're going to start with Alethea de Rogers, who's a research assistant professor from Boston College School of Social Work. And then we're going to follow that with Amanda Nguyen, who's from the University of Virginia, and she is an assistant professor there. So let's go ahead and start with you, Alethea. Welcome.
Thanks so much. So our team has actually been developing and evaluating an intervention that is more integrated. It's a family home visiting intervention designed to promote early childhood development and reduce household violence among families that are facing extreme adversity with children aged 6 to 36 months in Rwanda. And this intervention is called Segura Maranga. We're also now piloting the intervention in Sierra Leone in combination with digital tools to support supervision and fidelity monitoring of community health workers delivering the intervention. So we really leverage task sharing approaches in training and supervising community health workers who are actually providing home visits to try to reach families that were hard to reach and mothers that are harder to reach. In terms of the intervention content, it includes modules that are related to hygiene, nutrition, and early stimulation, as well as those focused on promoting positive father engagement, stress management, conflict resolution, and alternatives to harsh discipline. So one thing that sets this intervention apart is the focus on father engagement and engaging the fathers in addition to the mothers in the home. In terms of findings, we don't yet have findings from the pilot study in Sierra Leone, but we have robust findings from a cluster randomized trial in Rwanda, which showed significant improvements among households that had received the intervention on early childhood development, reduction of household violence, and also improvements in both maternal and paternal mental health at post-intervention. One thing to note, however, is that the effects on mental health were not sustained at the 12-month follow-up. So I think additional strategies to promote competency and ongoing training and supervision for these community health workers could perhaps help sustain those effects over time. And the intervention is also currently in Rwanda being scaled out to over 10,000 families. And we're leveraging and using a collaborative team approach in terms of an implementation strategy to support scaling of that intervention and maintaining delivery quality. So I would say in the future, leveraging implementation science strategies such as cross-site learning, as well as digital solutions that can provide further supports for training and fidelity monitoring of community health workers could help promote delivery competency of intervention content that is related to mental health, as well as maternal health and early childhood development, and can also help to better sustain mental health benefits of these types of integrated interventions in lower resource settings globally. Thank you.
Great, thanks so much, Minda. And I want to call everyone's attention to, there are a couple of interesting questions in the chat. So if any of you feel like responding to those, I think you addressed some of this about marginalized women and community health workers, how you can get to them, but there may be more aspects of that marginalization that we should all be considering that may be more in need of some of these services and integration. And I think the other question is also interesting. We're all kind of, I sense, focused very much on the, we're talking about maternal health, and this is really a life course mental health and psychosocial support need for women across the life cycle. So if anyone have any thoughts on those, we can come back to those, but I just wanted to call your attention to those. And I want to now pass it over to Amanda, who I threw those in front of your lap if you feel like addressing any of those, but I know you have some planned remarks, so I don't want to divert you too much. And I also want to continue to welcome other thoughts and comments or response to those in the chat.
Thank you, Phyllis. Yes, so I'm speaking today on behalf of my team of colleagues. Our project represents folks from Johns Hopkins University, my University of Virginia, and our implementing partner, Action Against Hunger. Our approaches have really been informed by a lot of our team's review and kind of stakeholder engaged prioritization activities around psychosocial supports that really highlighted this need to integrate these kind of considerations into basic humanitarian services as an approach, but also really specifically highlighted psychosocial support for caregivers and looking at the impact of that support for the kids in terms of a research priority. A second aspect of review work that our team has undertaken focused specifically on that second question around, we know there's this link between maternal mental health and child well-being. What do we know and what don't we know about interventions impacting on that link? And they did show some improvements in exclusive breastfeeding, but a need for just so much more research looking at what treatments for mom does for kiddos. So our program, in response to this, is evaluating a program called Baby Friendly Spaces. It's an integrated program into nutrition that ACF implements in many humanitarian settings. We're looking at it in Cox's Bazar, Bangladesh. So how it works is the BFS program is offered at these ACF-run integrated nutrition centers. So kind of targeting those mom-child dyads that are struggling in some way by seeking some nutrition support. Moms of kids who are receiving that nutrition support can also, in that same location, receive these kind of light touch psychosocial support services. But BFS also has a two-pronged approach. So it's focused on improving maternal well-being, but also simultaneously improving their care practices. So kind of providing these practical skill building exercises, as well as addressing well-being needs. In Cox's Bazar, what we learned is that fidelity had really drifted. And so again, this became very much an implementation question where what we were looking at is retraining, standardized supervision, session guides, et cetera. So not just does BFS help, but what does it take to run it well? Just one thing that we've hit on as it's co-located with nutrition, but it has its own dedicated staff, which is something a little bit different than what was talking about earlier. So that way we're adding support for moms through this nutrition program, but not adding burden of care onto those nutrition workers. So that's something to think about in terms of an integrated model. In another project, some of my colleagues are doing something similar where they're asking perinatal care providers to take on more care around psychosocial needs, but doing it in a group-based model to make that more of a feasible type of approach. So again, I think considering these innovations in staffing and delivery models to support that type of integration. And then just as one last point, as I'm out of time, going back to worker care, what we've really heard through supervision in our BFS study is this feeling that that our providers were lacking in support and lacking in training. And so at least anecdotally, what we've heard so far is that these improvements in the supervision structure and the training have really helped them feel more competent and capable and empowered and engaging more proactively and positively with their clients. So we're waiting for the data, but we're hopeful.
Great, thank you so much, Amanda. I'm sure others, as myself, are sort of busy thinking, and it's looking that we'll have some time to have some interactive discussion after this. I think now we're going to hear from Becca Levine, who is a senior maternal health advisor at USAID. You know, as you can tell, you've got a fairly opinionated group of panelists here that are throwing ideas and thoughts your way. And you, as one who better understands investments and how investments work and what sort of is the scope and vision for some of this integrated work or not, from your perspective. Go ahead, Becca. Thank you.
Sure. Thanks so much, Dilys, and thanks so much to all of the speakers so far. This is honestly could not be a more timely discussion and webinar. As just this morning, I was having a conversation with my colleagues. Sorry, I sit in the Office of Maternal Child Health and Nutrition. And I was talking with colleagues on the child health team, on the newborn health team, on the immunization team, nutrition team, talking about how maternal mental health is really one of these cross-cutting issues that impacts all of these technical areas that we are trying to advance and improve upon. And so we were talking, what is it that we need to know, right? What do we want to be focused on over the next couple of years within our office in terms of this space? And so there's a couple of things that I just would like to highlight for this implementation science and implementation research community. So I think some of which has already been mentioned. One is that there is a fairly robust evidence base on specific interventions that we know improve mental health outcomes, right? We know what those interventions are. But what we don't really know is how to implement those in different contexts, feasibly, cost effectively, and at scale. How to adapt those interventions to local, cultural contexts. And that is something that we're really interested in, is saying, okay, look, we know that this specific intervention works in this demonstration site in this one district, but how do we really scale this in a way that's institutionalized in a sustainable way and can reach populations at scale? So that's one area. I think the other piece that is really of interest to us is, of this evidence base of different MHPSS interventions, are there specific interventions which are most impactful for not just improving mental health outcomes, but also more impactful for improving other health outcomes, such as newborn health outcomes, child health outcomes, nutrition health outcomes, so that we can identify which of those interventions gets us, for lack of a better word, biggest bang for our buck. And I think the other thing that I just did want to mention is that we are very much thinking about this as a while maternal mental health is sort of our are a focal point in terms of introduction into this space, and perhaps where we are targeting women to the question around sort of the life course, realizing that once you have a functional mental health and psychosocial support system in place as part of a broader primary healthcare platform, those services are then available throughout the life course for adolescents or forever it may be, for whomever might need them. But I think, from our perspective at USAID, we are thinking about this within the framework of maternal child health and nutrition as an entry point for identifying women and again, ensuring that they have the well-being to not only survive, but to thrive, both for their newborns, their children, their families, their communities, and their nations at large. So I will stop there. I hope that was within 3 minutes.
Yeah, no, everyone is doing perfectly, which is really great to see, because that will give us a little bit of space and breathing room to dive into some of these issues a bit more deeply. Maybe I'll let Vicki have a first shot at any sort of also reflections, because sort of it's been a while. If you have a thought you want to add to this mix before we move to the lightning round, where we get each of you to give some recommendations, or or we see where the questions are coming from.
Well, I was really struck with everyone's comments, and particularly, as we, as folks are talking about the implementation side of things and the need to build capacity for the providers, and also the attention to provider mental health. I think that's definitely a new area in implementation science, and not only thinking about capacity building and scaling up, and the process for creating better quality service, but also thinking about what sorts of things can be built into the system, the internal context of an organization that can support and promote provider mental health as well. And so I think that's a really exciting new area that would be great to see movement on.
Yeah, I find it so interesting, and I think that this is a unique sort of forum as an implementation science collaborative with, I'm sure, members that are involved in different aspects of maternal health and mental health, and really beginning to think that, yeah, this issue is really broad and deep and is going to take a lot of, innovative thinking around it. I'm struck by what you said, Becca, about we need a sort of a mental health platform on which to strengthen the primary healthcare platform. And I'm curious as to everyone's belief about, in many of these settings, is the primary health platform strong enough to support the integration of a mental health platform? And maybe if any of you have thoughts on that. How do we want to do this? I'm going to, if anyone wants to raise their hand because you have something you want to say now, and I'll make sure that we pass it to everybody. Otherwise, I will just go back to the order in which we started. And again, if any of you have any questions or comments, please do put them in the chat. We'll try to pull them up from there. And if I don't see otherwise of anyone sort of dying to say something quickly, everyone will be patient and wait their turn. I'll go back to Nirja to see if you have some thoughts on this integration and implementation science perspective.
Thanks, Dilys, and it's been such an interesting session. Yeah, I think speaking about implementation science, there is a real dire need for research in low and middle income countries to test the efficacy as well as effectiveness of the needed tools and interventions that can support primary healthcare workers to deliver the care that we're speaking about at primary care level, at the community level, to improve maternal health as well as improve mental health of women as well as improve health of children. This research will basically help us identify the barriers and facilitators that we can then use to scale up these interventions. I think that's what we need to do, move beyond the research settings. And also this can then inform future programs as well as policy development. It's very important while we're doing this to involve practitioners as well as people with lived experience as equal partners in research. And also to involve policymakers right from the start. So they're engaged, they're a part of the process. And then this becomes easier when we're seeking, knowledge translation and incorporation into policies.
Great, thanks very much. And I think this issue that, speaking from WHO with the guidelines, there are programs that have been shown to work. And now it's really about the implementation science around how to contextualize them, the thinking healthy and the MH gap. There are things that implementation scientists can pick up and really start diving into some of those more nuanced questions about the how to do them. All right, let me pass it on to Rosemary. What are your recommendations in this space?
Thank you so much. I see there's a lot of potential from implementation science just now to showcase on what works. The first thing is to see that we already know that there is evidence that the mental health and the psychosocial support, it's critical, and it's high time that we have to integrate across all the broad areas from maternal and all the key areas. So I think there's a lot of potential to come up with evidence. Now we already have the policies, we already have the strategies, but what works? And how can we inform our programming? How can we give an opportunity for us to review and see that, okay, maybe this, the evidence, the contextualize the evidence, show that maybe we need to adjust based on what works in this continent does not really necessarily work in Africa. So I think that the implementation science focus should go into the users. Okay, maybe if we say that what works in Africa, how can we monitor? How can we do the research? How can we inform our programs based on the evidence? Yeah, thank you.
Thanks so much, Rosemary. Let's move on to our researchers and see if there's some other recommendations to add into the mix here. Patience?
Yeah, so building on the points about first integrating mental health and maternal health care, but also from an implementation science perspective and bringing interventions from one setting to another. The one thing I want to mention is thinking about how in all this we are providing responsive and respectful mental health care. We know that mental health is already stigmatized in our society, and we don't want to perpetuate that stigmatization within healthcare settings. And so we need to ensure that our mental health, I think through how to make our mental health interventions or ensure that they are provided in a way that is dignified, in a way that is respectful, in a way that is responsive. I think this will be important to not just winning trust, but also increasing engagement and support in the community.
Yeah, thanks, Patience. And that kind of was an interesting link to the first session, which I don't know how many of you attended, but this issue of trust and trust between the sort of NGOs and government officials and building trust is a really important thing. And I think there is certainly a lot of potential for missteps in this particular area. I'm also really glad you brought up stigma, because surprisingly that didn't come up until now. And I think that's something, I don't know whether we're taking for granted, but another area that I'm curious to hear reflections on. Charlotte?
Thanks. Well, yes, I think a number of things have that I was thinking have already been said, but I think that using implementation science to introduce existing WHO guidelines, we've got experience of that across the board around introducing the guidelines on the possible serious bacterial infection in sick young infants, and that's been done across countries in both Asia and Africa. So I think that we have lessons on how to do that, and that they were quite comparable on the issues that people found and the bottlenecks that people found in introducing them. but also, yeah, and I was going to build on the trust issue. I think that's incredibly important. That if communities don't have trust within the health system, they're not going to be accessing them, especially around issues to do with mental health. But yeah, I think, and also we need to make sure that the women, the mothers, and the communities, they have their voice heard in implementing, coming up with ideas on the best way forward to provide supportive care to women throughout their pregnancy journey.
Great, thank you so much. Let's move to the sort of mental health academic perspective. And maybe I'll throw out here now, it just came up that I'm recognizing that, we have a lack of implementers from our low and middle income countries that are actually working in this area. And we acknowledge that, and we recognize that we did reach out to a number of partners, but it's getting pretty late in lots of parts of the world where this will be relevant, so that we will need to reconvene this for other fora, but I did want to acknowledge that. Alethea?
Yeah, sure. So picking up on the implementation science perspective and how it can facilitate implementation of these integrated interventions, I would just like to point out that a key component of our collaborative team approach is cross-site learning exchanges. So in a cross-site learning exchange, you have lessons learned in supervision groups between supervisors and facilitators shared across communities or districts or agencies. And I think this has been a key component to help support the scaling of an intervention across wide rural districts or wide-ranging areas where transportation is often extremely challenging. And so I guess my thought, like an extension of that, is that, trying to have more cross-site learning exchange between implementers in lower and middle income countries and sharing lessons learned in terms of what has worked with implementation science strategies for scaling could help us, I think, better exchange and disseminate knowledge. So that's my idea for moving that forward.
Mm-hmm. Great, thank you, Alethea. And Amanda.
Yeah,
your recommendation.
Two thoughts that came up. One related to trust is what we've learned is just the need for strong referral networks as we do build trust and support further disclosures by women who are in tricky situations. Having the ability to respond to those and to provide the appropriate referrals. And oftentimes the kind of frontline and psychosocial workers need their own kind of backup supports to be able to refer those out. So just thinking in that systems framework. The other note I wanted to say as it relates to these contextual adaptations, something that we've been talking about in our learning collaborative is the need for greater kind of shared learning and documentation and taking a systematic approach to those adaptations so that, again, we can kind of learn from each other. So for example, across all of our projects in HERD, we're using the same frame adaptation documentation tools so that we can hopefully move the field forward in what adaptations are required.
Yeah, I just also to Amanda's point and also to respond to Alethea's point regarding the cross-site learning. That's exactly what we're doing in the learning collaborative for the mental health psychosocial program across the 5 studies that are part of this portfolio. And having the shared outcomes is really helpful because we'll be able to see impact on the same outcomes, even though the interventions are very different. As well as opportunities to look at how different interventions are adapted across settings. And of course, some of that will be unique to the intervention, but some of that will be more about about the context and understanding the context. And I think the lessons learned there will be really helpful across the board. But yeah, that's those are really great suggestions and definitely things that are that we see as issues in our own learning collaborative.
So maybe I'll sort of throw that back out to all of you, anyone who might want to respond. I think that through HERD, we've had the opportunity to develop and build the implementation science collaborative, the mental health collaborative, the women-centered care collaborative, in which we're trying to build these fora around implementation science in these domains and having cross talk opportunities like this one. I'm curious if others have any other suggestions or thoughts on how to build these, build, strengthen implementation science communities, partnerships, all of that sort of meta space that is so important. Not really meta space, but you know what I mean. Anyone have a comment there? Anyone from our audience who is anxious to say something? I'm sure there's probably lots that people could contribute to this conversation, or if you'd like to raise your hand to ask a question. I would like to, as we're waiting, acknowledge Patience's comment about where this fits into the whole issue of decolonizing global health and who is driving the work in this and every other space.
Maybe, Dilys, I could respond real quickly to Patience's comments and then also to Emily's question. So USAID, the Office of Maternal Child Health and Nutrition, through one of our implementing partner projects and in collaboration with WHO, is thinking through the process of doing a human-centered design and very woman-centered theory of change for maternal mental health, which I think would really help to contribute to sort of a broader learning agenda and perhaps think through some research priorities that we may not have thought of, because we're going to be thinking about this theory of change along a woman's journey from pre-pregnancy all the way through 1,000 days post-pregnancy, and doing this through a human-centered design where we're actually engaging women and patients and women with lived experience in this development process from many of USAID partner countries and low and middle income countries. So I think it's a way of making sure that we're thinking about the right questions, that we're asking the right questions, and that we're also being responsive to their needs and their identified priorities and concerns. So just wanted to, that's, one way we've been thinking about making sure that we're taking into consideration the priorities and needs and really letting women in countries where we are supporting these efforts take the lead in how we address those. And then to Emily's question around communities of practice, we are also in the process of trying to develop a terms of reference and a process for establishing a maternal mental health community of practice that is also really focused on healthcare providers themselves, program managers, and then patients. So women and others with lived experience to be able to share and exchange knowledge and learning and experiences. And so while it's not yet up and functional, we hope that that will be soon, realizing that there are also many other communities of practice out there and collaboratives like your own. And also wanted to mention the African Alliance for Maternal Mental Health, which also has a strong knowledge sharing network. So yeah, thanks.
Thank you, Becca. That's really great to hear and such important work. I think we would all recognize that. I think this comment, I don't know if anyone of the panel would like to comment on the research around adolescent pregnancies and the stigma associated with that and the particular mental health vulnerability. I think this gets to this area of, how focused do sort of some of these mental health efforts need to be, or should they be, when you think about some of the populations that are at particularly high risk? don't hold back.
Well, I could jump in quickly. It's not an area that I've worked specifically in, the area of teenage pregnancy and vulnerability, but I know that in Sierra Leone and some other contexts, there is so much stigmatization around teenage pregnancy that it's hard to even access those women, those young girls, and so many cultural mores that need to be considered. And a lot of movement just in communities that needs to be addressed in combination to help with the destigmatization. And so I guess I just wanted to point out that I think so much really requires deep knowledge and partnership with communities to understand the cultural context so that these young women are not put at risk and their needs are met as well.
Thank you, really important. Anyone else want to add on to that in terms of the adolescent pregnancy? Granted, it's a giant, enormous problem and issue. I also want to recognize, thanks, that was from Patricia Fish and Angela McCall, who's throwing out there whether anyone wants to comment on contributors to how are contributors to poor mental health and prevention being addressed along with solutions to improve mental health. I think this is prevention, treatment. It's something that I struggle with is how do you sort of justify large efforts in screening if you don't really have much to do in terms of treating, and what are those things in which contexts? Does anyone want to comment on that?
I could comment a little bit, just Neerja, I see you're going to as well. Just in terms of the review work that we did, there's a lot of recognition that so much more of the strongest evidence base is really centered around treatment programming, and need for so much more work around prevention programming, and really thinking through what does that look like and how do we measure those outcomes. And so often still, even programs focused on prevention are being measured in terms of distress and these other kind of deficit-oriented and symptom-oriented outcomes rather than those positive indicators of well-being that would map onto a more holistic definition of like the WHO definition of mental health, for example. So a lot of work in that area on the research side that we're doing around increasing our measurement, increasing our ability to do quality research on kind of community level interventions rather than targeting the individual, for example.
Mm-hmm. Just to add to that, Dilys, if I may, what we did is when we were providing evidence reviews for the postnatal care guideline updates, we had research teams who looked at what evidence was out there for prevention of common maternal mental health conditions, that is depression and anxiety. And based on the evidence that was reviewed by an expert group, we actually were able to make recommendations for prevention interventions in the postnatal period. So I think while we understand that there is need for more research, and especially research from low and middle income countries, we know that there is evidence to show that these interventions are effective and therefore need to be a part of the care that women receive during the perinatal period.
Thank you, Neerja. And I will sort of draw attention to what Becca just put, that interventions like group antenatal care, we've had that finding as well in a group antenatal trial we did for preterm birth, which didn't do much for preterm birth, might be because we couldn't measure it, but very well. But it did seem to improve maternal mental health and do have some prevention in terms of perinatal depression. And I think things like group care are an opportunity to think about how to optimize. Many systems are trying it out. Women love it, providers like it. There are system strains to do that. But I think that is an interesting thing, as well as the fact that the WHO has moved from the 4 focus visits to 8. So there's actually sort of this opportunity as health systems around the world are figuring out how to adjust their antenatal care programs, that mental health has the opportunity potentially to really be recognized and integrated in a meaningful way. I'm recognizing time. I want to turn it back to Vicki to have an opportunity to say any final words if you'd like before we close this out. And I do want to thank all of the speakers. This has been a really valuable conversation and really enlightening to me.
Yeah, I just wanted to say thank you to everybody, especially the panelists who gave their insights. I definitely learned a lot, and we will be sure to carry forward some of this in our future discussions with the collaborative and with others that are interested in joining us. I know that Emily said that she would be posting the new website for the ISC, the Implementation Science Collaborative. So for those of you who are interested in learning a little bit more about us, please check that out. We at the CUNY School of Public Health host the Knowledge Hub for the MHPSS portfolio, so you could join us there. Also to get some additional information on some of the projects that are going on in that space. And we welcome participation from everyone and look forward to hearing more from you all. And with that, I will close and thank you for joining us today.
Okay, I think we will go ahead and get started right on time with our third subsession of this Implementation Science Collaborative Satellite session. So without further ado, I'm just going to turn it over to our session chair for this session, Matito Watson. Over to you, Matito.
Thank you very much, Sam. Welcome, and thank you to everyone for joining us in the Implementation Science Collaborative session on moving persistent challenges into the mainstream of global health agenda setting. For those of you who don't know me, my name is Matito Watson. I'm a senior technical advisor for USAID in our DDI Inclusive Development Hub as part of the Children in Adversity team. I'm delighted to be chairing this session today with many of my dear colleagues that I've been working kind of shoulder to shoulder with on this work. And in today's session, we will be focusing on how implementation science collaboratives are really building capacity and increasing priority for development strategies to address children in adversity and disability rights, including those that are in need of that assistive technology. The session will highlight investments from USAID's Health Evaluation and Applied Development, HERD, project through a panel of short presentations and discussions, and as well kind of reinforce the importance that we put on this area within the Inclusive Development Hub and figuring out how we really mainstream this as part of our work within the public health sector. So we'll have a series of panelists, as I mentioned before, but before we get started, it is my great honor to welcome Becca Levine, who's the Acting Special Advisor for Children in Adversity within USAID's Inclusive Development Hub. She's also my colleague and sometimes my boss, so it's I'm very honored to have a chance to introduce her today. And Rebecca, would you get us started with a few kind of opening remarks on these two areas that you oversee as part of your work?
Thank you so much, Matito, and good afternoon, everyone. It's great to be here with HERD colleagues and other partner colleagues. Really looking forward to hearing more about how implementation science partnerships. Oh, and my child is really interested in hearing more about implementation science partnerships too. So excuse me, pretty soon we might be transitioning. Oh, shh, shh, shh. Okay. Here. You can listen with me, okay? So, sorry for the interruption. I hope this will be the last of these kinds of interruptions, but I am really glad to be here with you. We're going to hear presentations and discussions on children in adversity. Hold on.
As you can see, we're a very
right
group. Really try to incorporate a lot of children into the work that we do.
I'm grateful to have a friendly audience today, so thanks everyone. And I am looking forward actually to hearing from the panelists much more than myself, so I'll be pretty quick. But yeah, really glad that we'll get to hear much more about children in adversity and disability rights, including assistive technology, which are all critical topics that USAID has been advancing through HERD project investments, among others. And while these have been priorities for USAID, they have tended to be considered as complements to or even on the fringes of the global health agenda, in spite of their substantial areas of overlap and intersections with the global health agenda writ large. The problems that these issue areas seek to address are really big. In terms of AT, we know that global estimates indicate 2.4 billion people worldwide would benefit from physical rehabilitation services, inclusive of assistive technology, and that receipt of these services, which are often not available or accessible in low resource settings, allow those in need to optimize their functioning and promote their well-being, resulting in better income and education outcomes across populations. And when it comes to protecting children from violence, we know that nearly 1 billion children, more than 1/2 of all children in the world between the ages of 2 and 17, are victims of physical, sexual, or emotional violence each year, including bullying. And that children who experience violence not only require direct health services to care for physical and mental harm, but they're more likely to later practice high-risk behaviors related to substance abuse and unsafe sex, and are at greater risk for mental illness during childhood and as adults. So with huge implications for global health and development, these issue areas are also complex, requiring action and coordination within and across sectors, such as health, but also engineering, justice, child protection, education, and youth. Because of this complexity, implementation science partnerships, like the ones you'll hear from the panel today, serve a really critical function in linking diverse but essential partners and supporting them with harmonizing agendas and efforts, accessing needed resources and capacities, and connecting experiences, data, and evidence across settings. These partnerships can play an important role in supporting USAID's aim to offer people not only a vision of international development, but a vision of inclusive development, which is something that Administrator Power recently said. Accelerating access to assistive technology and protecting children from violence are both important prongs in USAID's goals to make aid more accessible and responsive, to focus on the needs of the most marginalized, and to allow people from more diverse backgrounds and partners of all kinds to participate in our mission. So I look forward to hearing more about the work of the USAID partner institutions represented on this panel, and to discussing how we can strengthen and broaden partnerships that build upon the work of these partners, the HERD Project, and others to advance these agendas. So thanks again, everyone, for joining and listening and participating. Thanks for bearing with my child interruptions, and I will turn it back to my colleague, Matito. Thanks, Matito.
Thank you, Rebecca. And I do think the work that we do over in terms of the Inclusive Development Hub is really intertwined with the work that's happening in HERD. And so we're going to listen to 4 short but substantial panel presentations. It's my big pleasure to introduce John Perlman and Mary Goldman, who are the co-directors of the International Society for Wheelchair Professionals, ISWP. And if you, John and Mary, are ready to go, the floor is yours.
Thank you, Matito, and welcome everyone. My name is John Perlman, and I'll be co-presenting this with Mary Goldberg, the co-director of ISWP. And just to get acquainted like we do now on Zoom, if you can, in the chat, share where you're from, your primary occupation, and any previous experience with ISWP, I think it'll help us understand who the audience is here. You can go to the next slide. So the International Society of Wheelchair Professionals was really established as a project to address global unmet need for wheelchairs. And so this really picks up off what Rebecca said about needing to provide not only devices and AT and to meet that gap, but to make sure that they're appropriate, there's a range of products, and that they're provided with appropriate service. And what we know from the WHO and other global stakeholders is that there's most of the need that's unmet is in less resource settings, and that's where the focus of our activities have been for many years. Next slide. So ISWP was envisioned 10 years ago as part of the key partners with WHO's GATE initiative on assistive technology. So you can see Wheelchair Secretariat as the bottom of the image on the left. And that was at a stakeholder meeting in 2012. For the last 6 years, we've been operating to support this activity. You can click through, I think there's a couple, I know there's a couple of animations, so apologize for that. And we were established to develop, to focus on 3 different points: to increase coordination, collaboration, to develop and promote evidence-based standards, and then to build product and service capacity, so workforce development around the world. Next slide. Since this initial envisioning of ISWP, we've had stakeholder meetings. You can click through one more, I believe. And this was in partnership with USAID and a previous funder of this initiative, World Learning. So this was before we received funding from HERD. And this established some key stakeholder priorities for the wheelchair sector. And this is really our roadmap based on the priorities that the partners that we had and several groups of organizations working in the sector. They and I'm going to pass this off to Mary. So we're working on all of these stakeholder priorities. The last 3, 7, 8, and 9 are where we're going to talk about, and Mary's going to highlight where we see as the best example of building this collaboration and implementation science in the framing of this meeting. So I'll pass it on to Mary to take the lead on the next slides.
Thank you, John. So John already mentioned that with the support of collaborations with GATE, USAID, and others to fund our work, we also are building off of a very solid foundation that was created by the World Health Organization and its collaborators, starting with the advent of the guidelines for manual wheelchairs in less resourced settings in 2008 that laid out 8 fundamental steps for assessing and providing and fitting and the maintenance and repairs and so on of wheelchairs. From there, they operationalized these guidelines by developing a series of training packages. And you can see here, starting with the basic level, going up to an intermediate level for those that require more support, to ways to manage meetings, to bring more stakeholders to the table, to push policy forward, to how to inform managers and so on. There's also a training of trainers package to help teach people how to train on wheelchair service provision. A little bit of a mouthful. We can go on to the next one, please. The only issue with these training packages per se is that they sit as static PDFs. So they haven't really been, up until ISWP, operationalized in a standardized sense and an evidence-based sense as online courses that have some interactive components to them. So they have been translated, these basic training courses, into up to 4 languages. So our basic level training has been translated into French, Portuguese, and Spanish. We hope to expand the others, but as you see, we've already expanded from the basic level and added the managers level, the stakeholders level, as well as training of trainers at both the basic and the intermediate levels of wheelchair service provision. They're very easy to access. You can get them by registering in our learning management system, which is WIN, and they're free to access. And we're also able to work with the trainers of these courses, what we call multi-tenant access, where the trainers are able to go in and actually look at the progress of their trainees as they progress through the course. We can move on to the next slide. Accompanying, you might have to click there. This is a little video. Thank you. Accompanying the basic courses, the courses themselves, we've developed some knowledge assessments, and these were designed to look at the effectiveness of the courses themselves at increasing knowledge. So we'll have trainers do these pre and post, as well as just get a cross-sectional understanding of where we are, the knowledge level of providers around the world. And then we're able to look at these trends based on profession, by region, by their experience level, and so on, And through really organic uptake, we've used social media and our networks, our collaborators, our working groups to promote the use of this assessment tool. And we've reached almost 6,000 test takers from over 107 countries. Next slide, please. So we took both the training products that we've developed and the basic test and developed a certification at the basic level for wheelchair service providers. And this acknowledges for a couple of years on our website that providers have not only received the appropriate training, but also have demonstrated by passing the test that they have the appropriate knowledge at the basic level. And they also commit to an oath, our ISWP ethical standards of practice. The certification process and its corresponding materials are available in English, Spanish, and French. There is a fee for this certification, but we have it tiered so that those from less income countries pay less than those in middle income countries and high income countries, respectively. There's a recertification process as well. And those who are certified are able to access a special area of the website where they're able to turn to other certified providers to get advice on complex clinical cases and so on. Go on to the next slide. Another core offering of ISWP and collaborative structure and process have been these communities of practice. So we have one of these for product standards, but I'm here to talk just a little bit about the one that we've established for academic training partners. I think we're now up to 29 or so from 20 different countries, academic training partners that come together bi-monthly to discuss the barriers and facilitators to integrating more wheelchair service provision training content into their training programs. And these have been from both formal training settings as well as informal training settings, for example, that are occurring within NGOs or clinics, for example. We can move on to the next one. Motivated by both the academic training partners who want more ongoing support for the integration of that wheelchair service provision training content in their programs, and that lineage, if you remember those, the WHO packages, we've gone up to this training of trainers, but we haven't really talked about how to specifically do this within an academic setting. So we developed the Wheelchair Educators Package. We're in the process of piloting this. This was based on a collaboration of 32 members. We will have content available in 16 languages. We're also representing 9 professions to guide the integration of basic wheelchair service provision defined by WHO for sustainable workforce development by OT, PT, and P&O. And we'll be launching the final version in September of 2022. And this is completely open source resource. Go on to the next one. This last one is just a little self-promo, how to get involved with ISWP. So we have a variety of committees and working groups. Anyone is able to participate in the academic training partners that occur bi-monthly. I think strategies that we talk about there would be applicable to other domains outside of just wheelchair service provision, by the way. You can subscribe to our newsletter from our website. You can also participate in our other communities of practices, including our standards one. You can sign up for membership for free. And we would encourage you, of course, to promote ISWP through your networks. And I'll include our tags as well as the website in the chat. And of course, join our global network for free. I think from there, I turn it over to David, one of our core partners.
Hi, everyone. My name is David Rousseau, and I am a prosthetist orthotist. I'm an associate professor of P&O at Jönköping University in Jönköping, Sweden. And I was asked or invited to present some examples of collaborations between ISPO and ISWP, and that's what I intend to do. Next slide. So an introduction of ISWP has occurred, but for those of you who aren't aware of what the International Society for Prosthetics and Orthotics is, ISPO, it's a global multidisciplinary non-governmental organization which has as its mission to improve the quality of life for persons who may benefit from rehab practice of P&O, or prosthetics, orthotics, mobility, and assistive technology. Currently, we have approximately 3,000 members from 113 countries, and there are currently 78 national member societies. These national member societies operate independently of the central ISPO International, and very often have mandates and visions which are regionally specific. Next slide. In 2017, development of new education standards for prosthetics and orthotics occupations was initiated, and these were published, I believe, in 2018. Something that occurred in that was the implementation or the introduction of wheelchair service training as a competency for prosthetics and orthotics professions or professionals. And this is something that they should acquire during their education. So in order to set a baseline and to kind of understand how wheelchair service provision was currently being implemented into P&O educations, there was a survey conducted to get an indication of this baseline level for provision. And this is perhaps one of the first examples of collaboration between ISPO and ISWP, because the content of the survey was largely informed by a survey that ISWP had used in previous projects. So that was an exciting opportunity for us to piggyback and collaborate with ISWP. Next slide, please. In order to explain some coming collaborations with ISWP, it's important to understand another concept, which is the Global Educators Meeting. The Global Educators Meeting is a biennial conference of P&O educators internationally. The image to the bottom right is the last GEM that we were able to hold, which was in Göttingen, Germany. Normally it would occur every second year. Unfortunately, due to pandemics, we sometimes have to postpone them. So our next conference is in June of this year, and I'll be describing a little bit about collaboration in conjunction with that. So the gem is, thank you very much. You read the room. What I really want to focus on, though, or highlight, is the opportunities that exist for collaboration between ISPO and ISWP. The alignment between our values and visions and how we operate are very, very similar, so that it feels very natural to be able to collaborate as two organizations. Both work in multiple settings, multiple countries, and both aim as part of their aims include the aim to increase access to quality services. The next slide, please. So the activity that I spoke about in conjunction with the Global Educators Meeting in June of this year is an opportunity for the ISWP in collaboration with ISPO to offer the Wheelchair Service Hybrid Training Series at the basic level as part of the GEM to P&O educators. In February of this year, we had a kickoff, we had two kickoff meetings and invited P&O educators to attend. And we opened registration to this activity. The activity will be 5 or 6 weeks in advance of the GEM and will be followed up by a one-day workshop on the 11th of June. So 67 participants expressed an interest in attending, and then we will shortlist this to 40 participants who will participate in all of these activities. Unfortunately, the on-site activity that was scheduled for the 11th of June has now been, because the conference has been shifted to a virtual format, will now be offered virtually. Following all of the activities, the participants will be then offered the opportunity to become certified as basic level wheelchair service providers via ISWP. Next slide, please. So I spoke earlier about the survey that has been a collaboration between ISWP and ISPO, and now a little bit of background and presentation of that as well. So in settings where educated wheelchair personnel are lacking, the use of other rehab personnel with appropriate education is encouraged. And the lack of adequate education in wheelchair provision is a major barrier to appropriate provision in low and high resource settings. And I think this is kind of highlights the importance of the work and the collaboration that ISPO and ISWP have, because this is attempting to fill this gap. This is one particular instance or one particular way that this aim can be filled. Next slide. So the aims of the survey were to describe the knowledge regarding the World Health Organization wheelchair service training packages, to describe which institutions or body have already integrated these packages into their training curriculum, using either the packages or other material, which institutions or bodies are planning in the future to integrate wheelchair service training in their training curriculum, and what is needed to support P&O training institutions to go through this process of integration. Next slide, please. Our response rates were quite high, 55% by institution of all of the institutions we were able to get in contact with, 77% response rate by country, as many countries include more than one education, and a total of 84 programs responded at least partly to the survey. Next slide, please. And the conclusions that we were able to draw and become very informative for P&O education internationally were that in 2019, when the survey was conducted, approximately half of prosthetics and orthotics programs or institutions were aware of the WHO wheelchair service training packages, had integrated wheelchair service training within their training curriculum using either the packages or other material, or were planning in the future to integrate wheelchair service training in their training curriculum. And also, they stated lack of subject knowledge within faculty is the major barrier to integration in curriculum. And I think this is important to highlight because this is something that ISPO and ISWP can work actively on addressing. Next slide, please. I would also like to, just in conclusion, invite all of those who might be interested in attending the GEM to do so on the 8th to the 10th of June, as well as the 11th of June with the collaboration that I just described. And with that, following slide, I would like to thank you all for the opportunity to present today.
Thanks, David. Next up, it is my pleasure to introduce Begonia Fernandez. Begonia Fernandez works for Together for Girls Partnership as part of the data-informed, evidence-based, multi-sector action to end violence against children. Begonia has been working closely with us at USAID on violence against children work for many years now, and I don't think there's quite an equal number of individuals that have been working as hard on some of these issues as Together for Girl and Begonia has been doing. So Begonia, with that, I'd like to turn the floor over to you to talk a little bit about your work as Director of Data and Evidence with Together for Girls.
Thank you for that introduction, Matito. And yeah, really excited to share with you all a little bit more about Together for Girls and how Together for Girls is supporting a global movement for data-informed and evidence-based multi-sectoral action to end violence against children. All right, so I think I wanted first to talk about some of the challenges that the field of violence against children has historically faced, and starting with the very limited data on the experiences of violence among children and adolescents and young people, especially sexual violence. And as Rebecca mentioned earlier, the field is very fragmented. Well, the field really, there are so many relevant sectors in the field of violence against children that often contributes to a fragmentation and really poor coordination among those different sectors and stakeholders. Historically, although that has changed recently, there was limited consensus on what works to prevent and respond to violence against children. And in general, we were seeing really a lack of priority given to preventing violence against children. There was more of an emphasis on comprehensive services, which is really important, but less was being there was just less of a conversation about prevention. And in general, there was a lack of a public health approach to violence. And finally, the ending violence against children was just not high on the priority list for many governments. So I wanted to kind of give an overview of how that landscape has changed in the past 10, 15 years. And I will be able to talk about sort of all the changes that have happened, but I did want to focus on the violence against children and youth surveys, the INSPIRE framework, and how Together for Girls has contributed to these different initiatives. But I couldn't kind of give this presentation without also mentioning the importance of having an SDG focused on ending violence against children, and as well as the creation of the Global Partnership to End Violence Against Children, which was launched shortly after the SDGs, and the many, many other initiatives and actors working on this issue globally. So to give a little background on Together for Girls, we're a partnership, like Matito mentioned. We have two sorts of partners. We have our organizational and institutional partners that you see on the right, and we have several UN partners, the Government of Canada, the US government through many agencies, including USAID and CDC, and we also have our government and country partners. And so these are countries that have committed to conducting a violence against children and youth survey, which I'll talk about soon. The model for Together for Girls is really focused on data and advocacy to drive action. And we work really focused on supporting governments to strengthen their prevention and response to violence against children, both governments and civil society organizations in those countries. And we see our role as really bringing those experiences and sharing those lessons learned from countries that are really committed to ending violence against children, and to also talking about the issue through the data that are collected through the violence against children and youth surveys. So a bit of background on the VACS, or the Violence Against Children and Youth Surveys. It is a national household survey that uses a 3-stage cluster sample survey design. These are surveys that are led by national governments with a lot of support from in-country institutions, as well as technical assistance from CDC as part of the Together for Girls partnership. It is a retrospective survey, and adolescents and young people ages 13 to 24, both males and females, are participate in the survey. And of course, extensive efforts are made to protect respondents and to ensure that respondents have access to services if they request them. The survey covers, of course, violence, physical, sexual, emotional violence, witnessing violence, and there are demographic questions. There are questions that help understand risk and protective factors for violence, health outcomes, mental health, sexual and reproductive health, access to services, and really so much more. Because of time today, I won't be able to really show the results from the survey, but I did want to kind of highlight some of the, I guess, key takeaways from the data that we're seeing from over 20 countries now that have published a VACS report. And I think importantly that this is data that most countries did not have before conducting a VACS, and it's data that is comprehensive. It covers not just levels of violence, but context, perpetrators, age at which the violence happened, location, immediate and more long-term consequences of violence. And it's data that really challenges a lot of the assumptions that we all have about violence, especially forms of violence like sexual violence that are less talked about and where there's just a lot less data. And also, very important that the data are comparable across countries. In the field of violence against children, one of the challenges that I didn't mention is that there are lack of standardized definitions for different forms of violence. And so having kind of the same survey done across countries provides us that data that we can kind of compare. So anyways, so since I won't be able to talk about the survey results, I encourage you all to take a look at the surveys that are available on the Together for Girls website. So very important and very kind of complementary to this increased availability of data on violence against children is the INSPIRE framework. INSPIRE is a framework of strategies and effective interventions to prevent and respond to violence against children. INSPIRE was launched almost 6 years ago now, and every letter in INSPIRE stands for a different strategy. And it's really all about kind of bringing together different stakeholders, different sectors around and rallying behind kind of a shared understanding of what we know works to prevent and respond to violence against children. And the INSPIRE working group has done so much in the past couple of years to really ensure that the different stakeholders, practitioners, frontline workers, decision makers are really using INSPIRE. And they've done that through workshops, and there is now soon to be a massive open online course, training of trainers, really ensuring that the capacity to implement INSPIRE is there. And they just continue to make such a big effort to ensure. And we've seen just so much, such a great response to INSPIRE and really rallying behind this sort of way of thinking about prevention and response to violence against children. And so finally, looking at kind of the results of the VAX process, we've seen that as a result of national leadership and commitment on behalf of different partners and the VAX data, more than 20 countries have strengthened their prevention and response to violence against children. And of those 20 countries, 11 have published comprehensive multi-sectoral national action plans to prevent and respond to violence against children. And our colleagues from the HEARD project are leading a landscape analysis in all countries that have gone through the VAX process to really kind of better understand what are the experiences of those countries that did the survey and that used the data to take a look at what they were doing and really figure out what needed to be improved, what needed to change, and to also strengthen coordination and increase funding for violence against children. So that's going to be such an important contribution to our work and to be able to advocate for countries to make bigger commitments to ending violence against children. And finally, for this audience, I thought it would be really important to mention that the VAX data sets are publicly available with the permission of governments that have implemented the survey. One way of accessing the data is through the Together for Girls website. And as a result of having this data publicly available, there are now more than 50 peer-reviewed articles that use VAX data as the primary data source. So for those of you that are interested in potentially using some of the VAX data in your research, I encourage you to explore further, and you can find more information on the Together for Girls website about that. And I think I'll end there, and I'm really excited for the next presentation because you'll have a chance to hear from one of our colleagues that can speak to this experience specifically for in Colombia. So thank you for your time, and I look forward to the panel and questions to follow.
Thank you very much, Begonia. Our final panelist today is Dr. Arturo Harker, who is the director of Imagine, a research center at the Universidad de los Andes in Bogota, Colombia. The government of Colombia has recently done its violence against children survey, and HEARD has been working closely with Dr. Harker in terms of really thinking around how do we move from the data into the action. And with that, I will turn it over to you, Arturo.
Thank you, Matito, and thank you for this invitation and to share the experience and our learning experience here in Colombia. So I'm gonna try to summarize what we've been doing for the last almost 7-8 years in this long process. As Begonia has said, this has been a very interesting collaborative process where a lot of actors have been contributing. Let's go to the next slide, please. So what's the problem and what has like our motivation behind what we've been doing? So in Colombia, approximately 40% of the young men and women that were interviewed in the Violence Against Children and Youth survey reported that they were victims of any of these three types of violence: sexual, physical, and emotional, which is a huge number. And more importantly, it was it made like a quantum leap from what we were using as the evidence to lead our policy against violence. There were a lot of things happening, but having this survey, this specialized survey, we went from using only administrative data of the reported cases of violence to design and to implement our strategies, to having this nationally representative sample, which has a special design to make visible this phenomena. So it's like the perspective is completely different. We now have information about the perpetrators. We now know that often it's someone known to the child or an adolescent, and that these events happen in familiar locations for the children. So thanks to this data, it's like a huge domino effect that happens in Colombia, but in every country where one starts to measure these types of hidden phenomena. So next, please. So this has been a collaborative effort. There's a long list of agencies, government, non-government, international, national, public, private agencies working. It's a large group. We've been working, just to mention some, the teams from USA, Together for Girls, the Global Partnership to End Violence, some academic institutions as Los Andes, the government, ICBF, the National Institute for Family Welfare, who leads all policy regarding children and youth, the Ministry of Health. So it's been like a really collaborative effort. And what I think is really special about this country's case is that there has been a special articulation, and the results we've been having really are a consequence of that great articulation and a lot of good work and great work, but that articulation has been really important. So next slide, please. So we've been working through a lot of steps just from having, sorry, that's in the Spanish version, but just starting with this evidencing or creating evidence towards the what's happening regarding violence, to getting to that place of having an implementation plan. That has been a long road. And in the next slide, I have like a timeline that thanks to Begoña, we have this timeline. Actually, this timeline starts before 2018. In 2015, we started working in the translation of this Violence Against Children and Youth survey. We did the translation, and we also implemented a cognitive lab to have a contextual appropriateness this survey, and this resulted in the survey that was implemented in Colombia, but also in Honduras and in El Salvador. And then finally, this process was led by the Ministry of Health, given that they had the longest experience measuring violence, in particular gender-based violence. They were articulating the whole policy regarding gender-based violence. And in 2018, the VAX was implemented. The CDC was it's a very important agency in this whole process. They trained the teams that went all around Colombia, laying the information. Afterwards, when we had the data in 2019, we started to do that socialization of the results. And this is a very important part when we did this data to action workshop, where we created this. I participated, I was invited to help leading one of the discussion tables, but we were able to start engaging multi-sectoral agents within the Colombian government and NGOs and from the civil society by sectors: education, protection, health. So we had the police, we had the Ministry of Education, the Ministry of Health, and we started having this discussion what to do, how like having a new picture of how harsh the situation was in Colombia, and how like the need we had to start mobilizing this topic and put it on the agenda. So in 2019 also what happened is that this became a priority to the president's office when they decided to join the global partnership as a pathfinding country. And in that year, we started supporting the government to create this national alliance to end violence. And it wasn't like a unilateral work of the government simply designing a strategy. It was more or bringing and adapting Inspire, that it was very like it's a very useful platform to design these plans, but it was more about bringing together all of the actors. This is a very complex problem to solve, so it needs like this complex type solutions where we have a lot of actors. So we started from that alliance to work on a national action plan. We have now a national action plan that is published. Like along this process, all of the agencies, national and international, that were supporting the country lead on this process, that was the ICBF, this Family Welfare Institute. These agencies were working behind and together as a group. And this multi-agency group was very, very important to really coordinate efforts, trying not to duplicate efforts, to have all the resources be the most effective and well used. So now we have this national action plan. And one last important part about this coordination is that it didn't end in just having a national action plan. It hasn't ended. The efforts are still there. For example, we started thinking as this multi-agency group on how to bring this national level plan to the regions, because here in Colombia we have relatively decentralized government, where the national government gives the general guidelines of and then general goals as a country, but the local and the territories and the municipalities have to come up with their own plans to implement those guidelines. So we did a very interesting endeavor. We coordinated and we went through this, was creating a Colombia Inspired coordination course, where we had between almost 100 government agents that work in the local secretariats, to give them the capacity to understand the basic evidence around violence prevention, how to use the Inspire framework, and to connect them and to start give them the basic tools and the basic capacity to start developing these local action plans, which is the actual way of bringing it down the national level action plan to the local sites. So this is like, there's a lot of complexity behind this timeline, but the most important part is there was a real real effort in coordinating all of our efforts. And I think that I can end there. Thanks.
Thank you very much, Arturo. Very interesting to hear kind of how the process has been put into, into work there in Colombia. It looks like we have just about 10 minutes for some quick questions. As I mentioned earlier, this is an area where USAID is very interested in really how to bring some of these issues forward, kind of out from the fringes of the health sector and kind of into the forefront. I'm joined today by my colleague, Michael Allen, who oversees some of the work around assistive technology while I'm working on the children's side. He is working on the assistive technology side. And Michael, from where you're sitting and kind of what you're seeing, what do you think has really been like the successes and the challenges about bringing the work around assistive technology to the forefront around global health?
Thanks, Matito. And I will try to be brief because I know we have limited amount of time, but yeah, I think the big picture is, as Rebecca mentioned, there's 2.4 billion people who need rehabilitation. Of that, it's over 1 billion people who need assistive technology, and 90% of those people that need is unmet, and that's highly focused in low and middle income countries. So obviously, in order for us to be successful in improving access to those assistive products, it really needs to be integrated into global health and mainstreamed. And so it's really an important topic that we're discussing. I think one of the core challenges to mainstreaming has been a lot of the global health indicators don't necessarily take into account the need for assistive technologies or other reasons. A lot of the global health indicators focus around mortality rates and survival, and not necessarily quality of life. So if we're talking about some of the challenges, I think those are some barriers in global health. And then the actual realities of providing assistive technology is that you need to have a screening process, a assessment, fitting, procurement, which sits within health ministries often and finance ministries. So integration becomes really important. Some of the successes that we've seen is starting to look at assistive technology as health commodities, and trying to leverage some of the lessons that have been learned in market shaping. So over the past several years, we've been engaging with multiple partners who are really instrumental in improving access to vaccines, antiviral medication, and trying to leverage those lessons that they learned in terms of trying to de-risk the market on the supply and the demand side. And so I think we're starting to see some inroads along that route. Part of market shaping also includes trying to define what those standards for products are and standards for services, because without that, it's very hard to be able to start to reduce the cost of the product and the service. And as Mary and John were describing earlier, ISWP has made some great inroads in defining the standards for wheelchairs, and ISPO, the International Society for Prosthetics and Orthotics, has also been very successful on the prosthetic and orthotic side. And one other success that I think we should really highlight is through partners, there was an investment case developed on the return of investment for providing assistive technology. And we see that there's, just with 4 assistive products, eyeglasses, hearing aids, wheelchairs, and prosthetics, there is a 9-to-1 financial return on investment for governments to invest in providing those products. And so that's been really successful, or really helpful in us promoting this to local governments, and seeing why this is not a cost, but an investment within the global health sector. So there's multiple success cases on a country by country cases, but obviously we don't have time to get into that. And I do want to save some time for others to speak. So thanks for the question, Matito.
You're welcome. And it's amazing, Michael, to kind of see that return on investment in terms of mainstream that in the health, in terms of assistive technology. We look at, I think, violence against children very much the same way. I did want to see if John, Mary, or David had anything to add to Michael's comments.
I think you said it really well. I think this unmet need is the major core area, an issue to address, and there's just no way to do it without deep engagement with governments. I think that the standards, at least with ISWP, that we've developed on the product side have been through engagement and helping lead committees at the International Standards Organization. So that has helped make sure that that's sort of an easily adoptable standard from a product side. And there really is no service standard globally. There's a couple of countries where there's an example. And I think what we've done, what Mary's done by leading a global team, is to develop really the best in class type of standard for services. So we're certainly in it and trying to focus on developing those tools for the ministries to adopt.
And interestingly, with an overlap with the other presentation, one of those early successes has been in Colombia, where there has recently been legislation passed to require some level of certification for wheelchair technicians. So that recognition piece is there and hopefully helps to drive progress.
Arturo, you work closely with the government of Colombia. You have a real life example going on. How, and Colombia's a little different because it does have a really well-financed social service sector. But what have you seen as kind of on the ground, the successes of really looking at the violence against children, bringing it to the forefront in terms of a public health response? And Begonia, if you want to add a kind of a higher level, I think that's great, but I'd first like to hear from Arturo.
Oh, Matito, that's a very interesting question. I think the biggest challenge there is having an actual mapping of the interventions that are cost effective or cost beneficial. Not even the costing side, just having effectiveness measures or in some kinds, not even, I'm not talking about that, even an RCT or hard evidence on the return, but at least of good practices, because we have a lot of things in the ground. There's like a very long trajectory of local innovations and NGOs that are doing prevention, violence prevention in Colombia, but they're not well documented. So one of the biggest issues is that now we know that there's a national intention to do a collective effort, but things are very fragmented. So that documentation side is, I think it's a big issue. And then, well, if you don't have even those listed, it's hard to then do the costing side of which one to do and how much would they cost.
Excellent. We do have a few more minutes, but one thing I think is important to talk about today is that we've just come through a couple years of a huge global pandemic, and we're dealing with very vulnerable, sometimes marginalized populations. And in terms of the work that you guys were seeing on the ground or even at kind of a higher global level, has COVID brought urgency in terms of the interventions and some of the work that you're doing in these sectors to really bring this to the forefront of the health sector? And what have you seen as kind of some of the impacts of that moving forward?
I was just going to say briefly that I think that as an educator, it would be irresponsible for me to say that there hasn't been a large effect on our ability to educate. So if we're going to say that there's an issue with educated personnel in the AT sector, certainly the effects of the pandemic have affected our ability to address that.
I would say at the same time, we've had to pivot, and we've actually seen some uptick in webinar registrations and things like that. But obviously the skills delivery training has been very complicated. We had some success in the Dominican Republic with training some folks on the ground in advance to serve as in-person facilitators with international subject matter experts and trainers on the other end, which hopefully could scale later on and train more people more effectively and faster. But no doubt, yeah, it requires some creative approaches and is more resource intensive at the planning stage.
Definitely. Begonia, what are you seeing kind of globally around the impact of kind of COVID-19 and the urgency of violence against children issues in terms of bringing it into the mainstream of health?
Yeah, I mean, I think it's unfortunate because everything we know about COVID and kind of containment measures points to increased rates of violence against children. And they're, just looking at kind of like how it's covered in the media, I think there is increased attention on the issue and maybe like a better understanding and some more urgency, I think, around the issue because people have been made kind of more aware of the effects of the pandemic on violence against children. And I think kind of on the intervention side, not necessarily just on the health sector, but there has been some innovation and there have been interventions that have pivoted and been adapted to be able to be delivered in a more virtual way. And Colombia even has great examples of how they were able to do that very early on in the pandemic to deliver parenting programs, recognizing kind of the need to support parents through this, difficult phase. And so I think that there are a lot of examples like that of and, it remains to be seen kind of what holds and how these interventions that adapted during COVID, how they'll kind of do long-term and whether or not they kind of continue with those modifications. But I mean, I think unfortunately it took something like a global pandemic to really get violence against children into kind of the headlines, but we are seeing kind of, we did see that. So we hope that it's kind of leading to kind of more long-term change and increased funding for the issue and preparedness for the next pandemic.
We're not going to have another pandemic, Begonia. So don't bring
Again, I have a quick question for you. The 20 countries where you've been able to implement it's very impressive. And I'm wondering if there are a few trends or what the selling points were where you were able to develop the models that I assume helped you to perpetuate that process in other countries that were like the original countries that did so. Whether you have any suggestions for us in trying to move our work forward similarly.
I think one strategy we've been trying to use more recently, I think, is being able to share the example of one country among other countries to say, look what this country was able to do with these certain key elements. It's not just about doing the survey, but it's about having commitment, especially political commitment at pretty high levels, and kind of giving that sharing kind of what are those key elements for success and a little cross-country comparison can only help to engage other countries that might not be making the same progress. So I think that's been really valuable. I mean, I think that the data as well, countries are really interested in having that sort of data, and they see the value in it, and just really it's about connecting people that have been working on this issue and letting them kind of share their experiences.
I think one thing to add to that on the success is, we really work within a country. So we're working through the, Ministry of Health and the Ministry of Social Welfare and the Bureaus of Statistics, looking at kind of enumerators within those countries and the decisions kind of happening within those countries. So there's a sense of not kind of coming from the outside to do this for a country, but there's more of a with rather than a for. And I think when people, violence against children is not a very comfortable subject for people to talk about. And when people actually see the data that their own country has been producing, it's really hard to kind of refute that. And I think when people see the high levels of violence, they really want to take action. I do want to check in with Marie and with Sam. I think we're at time. Do we have any wiggle room in here, Sam? Or are we going to have to wrap this up?
We have a few more minutes. Go ahead.
Okay. So I think that was like a big part of it as well. And as you know, as Begonia says, you know, for example, we've worked really closely with the government of Colombia. The government of Colombia has come in with like really high level political support from the First Lady's office and the ministries. And as Arturo said, you know, there's kind of a lot of the First Ladies of all of the governors of all those territories have come together as an issue. And so there's a kind of a bit of a movement there that has been really impressive. We're now starting with Honduras, and so we're gonna, you know, take some of what we learned in Colombia and hopefully be able to share that with Honduras. Please go ahead with your question.
So it's pertaining to Colombia, and I apologize, I was a little distracted before. What I wanted to know is, what are the efforts to help the children in La Guajira area, you know, on the Venezuelan border, the YU children?
Arturo, do you want to take that one, or do you want me to respond?
So it's a historically difficult region because of migration, because of the lack of institutionality. There are constant efforts. If you see the statistics of malnutrition and stunting, La Guajira is always there. It's like and it's a really, really difficult place to work. And I had like that perspective from the people that work in the government, from NGOs. It's difficult. There's a lot of efforts going there, but there is like you know, this expression of the perfect storm, where there's a lot of no institutions, a lot of violence, migration, some cultural issues of how children are viewing their cosmology. So it's a difficult, like it's that represents well Colombia, like having those like hotspots where everything goes wrong. But there are a lot of efforts going in, and I think it's it's not the result of no efforts.
One interesting effort that the government of Colombia has done work with USAID in La Guajira is, you know, they used to have, there's a high levels of malnutrition. There's a lot of issues around children's issues. And so we started having both the health team and the social welfare team go together when they were going out to do some investigations or kind of seeing what was happening. There's a large indigenous population up in that region, so there's a lot of very kind of strong cultural beliefs. And so to respect that, they were doing both a kind of a social welfare and a public health approach together, which seemed to really kind of improve and prevented some of the unnecessary separation of those children, especially those children that had to go to get therapeutic feeding in some of the therapeutic feeding centers. So as well, you know, the government of Colombia has stepped forward quite a bit in terms of providing those social services and health services for the Venezuelan refugees that come right over the border up there in La Guajira. Any last questions? We had one more question, but Sam, I think we're at time and need to wrap up.
Yes, please.
Okay.
Yes.
Well, on behalf of this panel, I just want to thank everyone for joining us here today. The issues around assistive technology and violence against children are really integrated and affecting what's happening in terms of our health systems and our public health approaches. I can, of course, speak a little bit more knowledgeably on the violence against children side and how we are looking at it as kind of a public health issue and trying to integrate that into some of the work happening. And at the same way at USAID, we're really trying to make that happen in terms of the assistive technology work going forward and have it not so much on the fringe or a niche area, but kind of integrated across. So I do want to thank John and Mary, David, Begonia, Arturo, and Michael for joining us, and Rebecca, who apparently maybe had to run off on a child issue, for joining us today on this important topic. This is something that we always feel near and dear to our hearts. So anyone that wants to have a follow-up conversation or get more information, please feel free to reach out to any of us. I think it's something that we can talk to you all day about. So with that, any last words from our panelists?
Thank you, everybody.
Yeah, thank you. Nice to see
Thank
everyone.
you.
Thank you all so much, and
Thanks,
have a great,
Matito.
great Tuesday,
Bye.
everybody.
Enjoy. See ya.
Good afternoon and good evening, everyone. On behalf of the Implementation Science Collaborative, we're really excited to have you join us for the fourth session of our day-long satellite session today, in which we'll be having a conversation about strengthening the global public health workforce. I'll turn it over to our session chairs. Thank you very much.
Good afternoon, everybody, or whatever time zone you belong to. Welcome to our session. And I'm Ayman El-Mohandes. I am the Dean and Professor at the CUNY Graduate School of Public Health and Health Policy. Today, we welcome you to this important event of the usual conversation of town and gown, or field and not so ivory tower, I hope, but to emphasize how we are trying to work best together. I hope that this session, promising to you, will be positive and constructive, since we have so much to share. With me today from the gown side, from the academic side, is my dear colleague, Steph Bertozzi, who is the Dean Emeritus of the Berkeley School of Public Health. And joining us is also my dear colleague, Ruhul Ramaswamy, who is Professor of Pediatrics and Co-Director of Research at the James Anderson Center for Health Systems Excellence at Cincinnati Children's Hospital Medical Center. And co-chairing this with me is a person with whom I have worked in the field, be it dabbling in the field as an academic, is my dear colleague and friend, Eckhard Kleinau, and he will present himself to you as well as the participants who are from the implementation side. Eckhard, are you there?
You're on mute.
Just unmute yourself.
Oh, I'm following your bad example, Ayman, and thank you so much. It's a great pleasure being here with you and all the participants today. My name is, as you said, Eckhard Kleinau, and I'm a senior advisor with University Research Company, URC in Bethesda, Maryland. And I most recently was the director for research and evaluation on the Human Resources for Health in 2030 program. That's a USAID funded, that was a USAID funded flagship program for human resources. It's my pleasure to introduce our implementing partners for today, starting with Esteban Moreno. He is the country director for Heartland Alliance International in Colombia. We are also joined by Alison Foster, and Alison is the strategic growth and business development advisor at YHER. And I don't know whether Sisse Wagnu has managed to join us today. He's a design, monitoring, and evaluation specialist with World Vision International. So welcome to everybody, and I'm handing it back to Ayman. There's one more person to introduce, I believe.
Indeed. To keep ourselves real, with us today is Troy Jacobs, who is the Senior Medical Advisor, Office of Maternal and Child Health and Nutrition in the Global Health Bureau of USAID. Welcome, Troy, and I hope today the conversation will cover all the topics of interest, but I will start with Eckhard, perhaps asking our field practitioners where they see domains where greater participation from their side could guide us in the way we train our professionals.
Well, thank you, Ayman. The challenge, certainly from the implementing partner perspective, which I have been all my life part of, is finding the technical capacity to design and implement implementation science studies. And so my question to our panel is really, are those resources readily available? And what issues are you encountering? And you can answer those from different perspectives, obviously. One is our partnership with academic institutions. Are we helping to train implementation scientists? Are we providing hands-on opportunities? But also, once those resources are there, once people have been trained in implementation science, are they readily available when we think about developing studies, designing studies, and implementing studies? So with that, I'm throwing this question out there, and please, Alison, Sisse, and Esteban, what are your perspectives on this issue?
Thank you for the question. Good afternoon or good evening to everyone, and thank you so much for this invitation. I would like to start saying something about the context where we work in Colombia. We're experiencing a very dynamic and multi-factor context with humanitarian and development issues happening at the same time. We were close to get a progress on our peace accord implementation, and unfortunately that hasn't gone as planned. The armed conflict has been reactivated in the last years, and with that we also have received an influx of Venezuelan migrants and refugees in our country, which has exacerbated the humanitarian needs. In this, we need more and more human resources and with high capacity to respond to the emergencies. The emergencies can be very acute, what happens in the armed conflict, and when we see the influx of migrants, either by walkers or in transit in a very risky environment that is our country. So we have very few opportunities to provide services. Some of those opportunities are unique. Sometimes it's just one session with a participant or a beneficiary. So we need very skilled professionals. But in this context, not all the professionals are willing to work under the conditions that the context provides, the same risks, sometimes difficult opportunities to find other conditions of housing and livelihoods. So I think that our challenge is to find trained professionals that will be during the length of the response that we're giving. Our specialty is mental health and psychosocial support. We partnered with health institutions to provide direct primary health services, and they do also face some challenges, but turnover is a factor due to the conditions of the context that could accelerate the changes on the team and the need for us to keep training personnel. We face that challenge, and we also face the challenge of working with both government entities and our implementing partners that need capacity building. And the same turnover affects them. We see that we want to provide skilled and high quality services that could be just once, like I said, one unique opportunity, but also think about creating and developing that capacity within the staff that will be more sustainable in the entities or in the government institutions that have the need to respond to these emergencies. So
thanks very much, Esteban. I want to give a chance to our other panelists as well, and keep your thoughts. We'll come back to you as well, and thank you for describing the situation that you are facing in Colombia. How about Allison? What give us your perspective, please.
Unmute us again, please. Unmute yourself.
Yes, I'm just following.
Yeah.
Tradition, I mean, really.
It's risky to mute yourself, isn't it?
So I'll just try to give an overview. I really appreciated Dr. Moreno's input on, what our health workers are facing now in this flux. And I work all over the world, but let me look at Sub-Saharan Africa, where Dr. Tarub Farahman has asked me to talk about some of Wyher's experiences. But we work very much in trying to give voice to those who don't have it, women and marginalized communities. And in that vein, we work with health providers and try to help them to look at what are you doing, and is that actually improving the health of your clients and the population you serve, and are you meeting those needs, and are you delivering quality services? And I think that many of those challenges that you just mentioned, Dr. Moreno, the other many challenges they face in conflict zones, which are expanding with new and coming in populations that they're unaccustomed to for various reasons, and also COVID-19 and other pandemics that they suddenly face. They're short-staffed. Motivation is challenging depending on the resources they have at hand. You have some nice equipped hospitals, and then you have the low-resourced areas, which are quite varied. So they have been trained and in theory would love to have research as part of what they do, would love to partner with universities and see what kind of interventions might work best, whether they be clinical or more socially oriented, and what combination of that. They're also challenged and asked to incorporate the clientele that they serve in that process of evaluating what is the quality of service they have and how can they improve the services and the system that serves them. But I just think that asking them to do that is so challenging, and we're trying to build the capacity to do that in low resource areas. Look at indicators that they actually can measure and actually can partner in measuring, and not just the process indicators, but what are those outcomes they're looking for, and what is the impact they're looking for, and how will they know? I mean, it just basic. And having people come in and researchers come in and work with them to collect data or to observe something there's an ownership gap. And I think that, if we can, what's in it for me, if we can answer that question and make it valuable and make it meaningful, I think that that's something we can do, because I think that in theory, it's very welcome, but when it happens, it is an added external burden. So I love this conversation we're having, and I think that we can all learn from each other. So thank you.
Great points. Thank you so much, Allison. Sissy, what about your perspective? And unmute yourself. There you go.
Yeah, thank you. So my name is Isai Wagner. I'm a design and monitoring and evaluation specialist with World Vision. So as you guys might know, World Vision is a faith-based organization working in more than 100 countries all over the world. So we have a different approach when we think about health. We usually think health in terms of being a community-based approach. So that means usually we work with frontline health workers, community-based health workers, this frontline, the first line of defense in terms of health education, in terms of responding to crisis or any kind of epidemics like COVID-19, for example. So if I give you an example or some of the challenges that we had in the last 2 years because of the COVID-19 outbreak, in most of the countries that we have been working in, there was health resources where most of the, much of the health resource was diverted toward this outbreak prevention and response, which means other important health matters like preventive education, health promotion activities, or malaria or tuberculosis or HIV/AIDS, they were somehow forgotten. And in addition to that, the quarantine policies also had an impact on house-to-house visits, NEC visits, postnatal care, or any kind of, mass education campaigns where we usually have been working on. And I think one thing that we can benefit from the research institutions or from the academic community is, I know that there are a lot of research products out there published somewhere in a journal or somewhere, anywhere. But, contextualizing them and translating those, knowledge products into action, taking into account the local contexts, like some of the contexts that we are working in are really fragile and insecure locations where priorities are different, where there are so many other variables that we have to take into account when we are translating one research product into action. So how can we be more effective and efficient in terms of translating a knowledge product into a local context? I think that is something that we really can benefit from. And also, how can we build health systems? Like, how can we make them more resilient towards, any kind of shocks? Or, for example, if something like COVID-19 happens in the near future, how can we respond to that? Or how can health systems in low and middle income countries be, can adapt themselves to such kind of crisis and be able to manage also other health priorities which they have? Because we observed that many people were dying from malaria and tuberculosis while the world was focusing on COVID-19. So
yeah, good point, Sissy.
Yeah,
I don't want to stop you there, but I also want to get a chance looking at the academic side. I think we have you made all of you made three important points. The need for highly trained professionals in Colombia. And that certainly would, I think, would include scientists who can accompany programs. The added burden on programs when there is external research going on. And then I think one of your important points, they say, was how do we make better use of research and the findings that we already have and translate them into better programs? I wanted to invite our audience. Is there anybody who wants to add from the implementer's perspective before I hand it back to Ayman and introduce the academic perspective? And if you don't want to raise your hand, put your comments in the chat, please. But I wanted to give you a chance. Anybody who wants to add anything to what was said so far? I'm counting till 3. Okay, no hands. Ayman, it's all yours.
Yeah, one of the things that occurred to me, and we have two very accomplished academics, but also very seasoned field practitioners, both Steph and Rohit have not sequestered themselves in their office hours at school, but have really been in the field up to their knees at various stages of their career and up till today. And I think that in global health, perhaps more than in any other field today, we have this chimeric product of the academic practitioner or the practicing academic. And so I think what our colleagues, what Sissy said and what Alison said, and also what Esteban said, is that it becomes a problem when these two things are not put together. The fact that Alison said, we don't want people to be doing research in a way that is burdensome to us, and she's right. I mean, if we're doing an evaluation in the field, the practitioners need to benefit from that activity, if anything, very immediately. The point that Esteban made was we need, this industry needs to continue to produce people because my turnaround is crazy, and they come and they go and they come and they go, which is really a big problem, because I feel like our role does not end in the classroom or on campus, but we need to also continue to provide resources to people in the field, so that the people that you have, Esteban, find that polish or the resources that also Sisay was talking about. He said, you know, you cannot sequester knowledge. I want knowledge to be easily accessible to me, be they instruments of measurement or any other academic products. So I will first start with Steph and ask him if he can tell us more about his experience as the academic practitioner and what he has learned from this dual role, this chimeric role, in being effective both as an academic and as a practitioner.
Thanks, Ayman. It's great to be here with all of you. One thing that question makes me think of is that it's easier in academic institutions that are not in the US. When I first came to Berkeley after many years at the National Institute of Public Health in Mexico, I went to visit Sacramento, which is our state capital and close to Berkeley. And I said, listen, I came to Berkeley to be dean. And I went to Sacramento and I said, listen, I'm used to being in a place where the Ministry of Health thinks of us as their sounding board and consulting body. I'm used to having the minister, have my number on speed dial when something comes up that is in my niche of, health economics and public policy or whatever. It seems that at Berkeley, we never hear from you. So this issue of, what the relationship is between academia and practice. When I worked in Kinshasa, the School of Public Health and the ministry were much more closely connected than we are. And in, I think, most institutions, academic institutions in the US, I suppose Johns Hopkins might feel that they have a special connection with Washington. But so I think that, and our illustrious alum, Larry Dean from Berkeley, wrote a paper once on the fact that in the US, we need what he calls revolving door public health, which is that people should be practitioners and then be academics and then be practitioners and then be academics. This idea that there should be much more porousness between the academy and the field. And I agree with him. I think that it's healthy for both sides. So I will say that I have found it difficult in the US, but I've certainly been working on that. And I think many people today recognize the importance. And in some ways, COVID really brought that to the front because it forced so many academics in the US into an interface role with various implementing and public sector entities. What I'll say, though, is with respect to implementation science, it's new enough in the US and in other countries that I don't think we have figured out how to do training for implementers or for public health students. I think we're still in the process of figuring that out. And I would love to hear from our implementing colleagues on this call more about which specific knowledge and skill areas in implementation science do they most need. I've been involved recently in trying to divide up the field of implementation science into mini modules or mini courses so that people could mix and match the things that they want to learn. I'm really interested in hearing about what are perceived to be the biggest gaps in the field and how those of us who are mostly in academia could best respond.
It's a very good point and really segs very well with our colleague and friend Rohit, because Rohit just published a paper responding exactly to that point, where the title of the paper is The Learning Needs for Implementation Science Training in LMIC. So you couldn't have asked a better question that I can shunt directly to Rohit, and he is going to unmute himself and give us some of his wisdom on these competencies and how he believes they can be shared directly with learners, but also with practitioners.
Yeah, thank you, Emma. I'm not exactly sure this is going to be wisdom. It really is still very much of an exploratory process, and we're learning as we go. So I'm certainly the last person to say that I have all the answers. But as Emma said, what we did over the last few years is we had a global set of interviews with a variety of stakeholders, 43 interviews across the globe in Sub-Saharan Africa, in Asia, and in Latin America. And these were people who self-identified themselves as implementation researchers, implementation practitioners, policymakers, funders. And the idea was to try and understand exactly the question that Steph asked. What is it that is needed that would advance not just theoretical, technical knowledge in implementation science, but really be able to provide these different stakeholders with what they need in order to take what is known of this field and put it into practice. And there are 3 or 4 key things that came about. And the first was that really, I think as some of you have mentioned, there isn't a single consistent way in which a lot of the implementers in these settings can acquire knowledge about implementation science. So a lot of them have acquired it opportunistically in bits and pieces. And so depending on who has taught it, depending on which particular workshop they've attended, they have picked up pieces that they are now trying to kind of use in the field so that they can improve the quality of their implementation. So this idea of having this integrated body of knowledge that then people can pick and choose from and contextualize, that doesn't exist. And so people are stuck with having whatever tools they've learned and trying to kind of force fit it into their applications. The second key piece was, where is the knowledge generated? And of course, much of implementation science right now comes from Western settings. Most of it comes from, fairly narrow applications in Western settings related to how clinical practitioners take evidence-based interventions and put them into clinical practice. In global health applications, where we're beginning to think about large-scale program implementation, it's not so much a question of clinicians taking evidence-based interventions and putting them into clinical practice. It's a question of trying to put together a package of interventions, some of which are evidence-based, some of which are translated, some of which come from perhaps quality improvement projects on the ground, and to be able to package them in a way that is contextually appropriate. There is very little training that from the Western models that support that kind of work. And so a lot of the implementers have been forced to kind of try and piece together from the bits and pieces and try to figure out how to make it work. The third piece is the whole idea of kind of mentorship and support. So several of the implementers have mentioned context. Context really matters, because the idea is that you have to be able to have a deep understanding of how to take some of the models and theories and frameworks in implementation science and make them work in your particular setting. This is not, while academics from the West and perhaps even can provide a general introduction to the body of knowledge, its contextualization, its translation needs to be done by local academics who then serve as mentors to the implementers so that they can work together to try and understand which of these tools matter, which of these tools can be translated, and which of these tools are not relevant. That critical mentorship role doesn't exist. And often people who have served as mentors still come from the West who have really no idea about what the local context is. And so the third piece that came about was the need for developing a body of mentors, a cadre of mentors around the world who are able to perform this translation function. And that's the third thing that came about from our assessment.
Thank you, Rohit. Carolyn Taylor from our audience says, while NGOs and advocacy organizations strive to provide beneficial programs and resources for their target audience, they frequently struggle with the challenges of how to record their progress and success. Building relationships with implementation researchers can assist with this, and these partnerships can provide an avenue to perform research in a way that benefits and respects both partners and participants, and build a bridge between research projects and service provisions. You said it so well, Carolyn, but I can tell you that, that is the ideal world that we're looking for, right? But we also have, Rohit has his hand up, but I will say, having worked with Eckhart myself, I was always very, very much in admiration, not just of his intelligence, but also of his incredible expertise. And at the end of the day, we may need implementation scientists at that level, where you may call them researchers, I may call them Uber evaluators, people who have the broadest insight and the deepest insight into evaluation that can bring this expertise to assist in some of the programs. And Troy is with us. Yes, I will recognize your hand in a minute, Rohit. But we have Troy with us on the screen, and we know that there needs to be mechanisms where the funding agencies also value this kind of a relationship between the academics and between the implementers, but we need to present it to the funders in a way that's attractive to them. And first, I will ask Eckhart to give us his perspective, because he's done a lot of that. Then I will ask Troy to give us his perspective. We'll get back to you in a second, Rohit. I will be with you in no time. Eckhart, what are your thoughts on that?
Well, thank you. And if you see my face reddening, it's the filter in Zoom. I appreciate that very much. And I just wanted to acknowledge, Ayman, I think why we have been able to work so well together, because you do understand context. You do not just wear your academic hat, but you also understand the side of the implementer and the challenges we are facing. And I can draw on our two most recent studies that we are just completing. One was in the Philippines, where we looked at enhanced supervision. Enhancements meant the digitization of supervision checklists. And that was a group randomized trial. And a more recent study in Malawi was a randomized controlled trial of a mental health app. And the challenge, there were several challenges. We are working with University of Malawi together, and the challenge there is aligning our timeline and our objectives with the timeline and objectives of the local researchers. They are in an academic year, they teach. And here is an implementing partner in need of research resources. And the timing was really difficult to align, because obviously people are not going to drop everything else just to work on a new research project. So that is one of the challenges. The other is, and that has more to do with the kind of training, are people really ready to be to design and to implement randomized controlled trials? It requires a certain experience. And I think what Rohit just alluded to, people may have bits and pieces, but they may not really have enough knowledge to implement a full RCT. So that's another challenge. And yes, we would like to build capacity and train while we are doing it, but that's also very difficult, because we are moving at a much faster pace from the implementer side than the academic institution may have the bandwidth to follow. So just wanted to make those 2 points, but it's a real struggle, but it's also extremely important that we do better.
Well, you're making a good point, and as promised, I just wanted to ask Troy, so how do you encourage this approach? And really, is USAID interested in funding randomized clinical trials?
Whether we are or not, it's often there's a limit to resources. And I think we need to put it in the context of discussions that we've had throughout all the 4 sessions today, as well as a larger discussion when we're talking about decolonizing global health, and whose perspective are we taking at USAID. And it's not unique to USAID. I mean, we're dealing with a bureaucracy that has habits and traditions and certain types of behaviors are encouraged, and this makes it very hard to change. And this is true also, you can find in academia and other places. What we've tried to do, I think, and this was before COVID, COVID's very important to our thinking going forward. In the design and implementation, we were looking at ways to bring in junior staff, our new partners, and this includes things that we talk about a lot in implementation research, using human-centered design and stakeholder engagement, co-designing, breaking large activities like large clinical trials into actually very doable smaller projects that are relevant in those local contexts. We've had a challenge, when you're talking about, we have capacity issues, in various countries, there's been a bias that we have been struggling to overcome, the practice and research within the agency. And there is, incredible interest in building capacity for nurses and, clinical officers, community health workers, and various cadres of health workers in countries where we're working. But the bandwidth and the interest for developing capacity for implementation research has been very challenging. And it's been unfortunate because, like Steph was saying, this is something that you would think would be very attractive, whether we're talking about, developing capacity for implementation research. I do a lot of work with quality improvement. That's a skill set that seems like it would be relevant and people would want to take up, and it more useful than, traditional clinical trials methodology and learning all of that and trying to figure out how you're going to use those skills when you're in a busy health center in Zambia or somewhere. The architecture has changed too, and I think that this is very important as we think about access and what we're doing is sort of the knowledge projects in local contexts that my colleague was mentioning. Prior to COVID, and we saw this in the sessions that we had today, is that partnership was very important. Collaboratives, they go by very different names. Research networks, whatever you want to call it. This is a very important part of what we do in terms of capacity building. At USAID, though, there has been a mindset that you really need to be on the ground, and all of this sort of partnership, it's nice, but this is where the action is. What COVID has shown, and it's changed the power dynamic, that people that did not have access before suddenly have access and are on equal standing with people. What senior faculty, junior faculty, students, we can all get online and, we're there. And so as we are going forward, we really need to think about how these partnerships and collaboratives are working. They're going to be very important for capacity development, but we're at a pivot point because we realize from the last 2 years that it requires a lot of work and planning up front if it's going to be successful. And there's a strong desire to go back to those old habits and traditions of, we go in country, you have all the people from the donors or from the, organizations in high income countries flooding in. That's not where we want to be. That's not going to advance, our discussions of decolonizing global health, building capacity, and doing better implementation research, which I think we all want to do. And I'll leave it at that. We can talk more if we want to explore some of those.
I think part of your conversation may have been directed at Steph, but I'm going to hold that for a second. And Rohit had his hand up, So first, I wanted him to make his comment. Please unmute yourself. And I was wanting to ask Esteban from his perspective, much of what you have heard, does this make sense for foreign institutions coming to bring assistance in the technical and academic world? Or do you feel like your local organizations, your local universities should be playing more of that role, especially that you're talking about the rapid turnover? Rohit, back at you.
Thank you, Raymond. And actually, I was going to make a comment about 5 minutes ago, but it's all the conversation has been very relevant to what I was going to say. So I was actually reacting to what Carolyn said, and I wanted to heartily reinforce the need for good documentation. Because the only way in which we can do good implementation research is by making sure that we're really understanding the processes of implementation and how they work in the local context. The RCT, so coming back to what was said earlier by Troy and Eckhart around the different methodologies. So while it makes sense for using randomized control trials, for example, to understand whether particular interventions have can be attributed to effects, we do tend to be outcome obsessed. We really do need to be able to move from outcome to process. And this documentation that Carolyn mentions, there isn't a space for that. And that's because research projects often don't pay for, don't support, don't provide places where detailed process documentation can be published. Likewise, the role of documentation falls on implementers who are busy implementing, who actually don't have the time to take on the burden of documentation. So we have to be able to think about how do we begin to grow the research capability, which is not only about outcome evaluation and RCTs, but process evaluation, and then be able to provide within, so for example, USAID funding or other funding sources, the mechanism for us to be able to do good and critical process documentation that allows us to be able to understand how the implementation process works. Thank you.
Thank you, Rohit. Steph, how about you? Town and Gown working together, research, randomized clinical trial, breaking it down, making it palatable to the funding agency from, I guess, a policy perspective, a strategy perspective, to help bring them a product that they are comfortable with.
Well, I think that I would say it's been close to 20 years, not quite that long, that the funding agencies became very enamored of impact evaluations. And I think really led more by the Inter-American Development Bank, the World Bank, and others who supported large impact evaluations. And it slowly became to be a best practice that when you start to fund a large program, whether you're a government or a bilateral organization or multilateral bank, that you would want to build in an impact evaluation so that you could document whether you're actually changing outcomes or not with this implementation. And I'd like to think that implementation science is starting its growth where when people are funding large-scale programs, they are thinking about whether the program is being implemented as well as it could be or should be. And one of the things that I think is a bit difficult with respect to training in implementation science is that if there was sort of one distinguishing feature of implementation science in the US, I think it really has to do with its outgrowth from the diffusion of technology perspective. What does it take to get technology to be taken up more quickly when something has been shown to be effective? And I think that in the development world, the focus is really more on how can programs be implemented more effectively so that for the same investments, they achieve greater impact. And whether that's a quality issue or a coverage issue, but the idea that we need greater efficiency in terms of results for the investment. And so impact evaluation is great, but as Rohit said a second ago, if we're focusing just on outcomes and not on the process, we're not looking at how the processes need to be optimized to achieve better outcomes. And I think that that's where I hope both funders and governments and implementers are going in terms of recognizing the utility of marriage with implementation science. And, you know, for better or for worse, the world's management schools have been largely focused on the private for-profit sector. And I'd like to think that implementation science is a lot of management science, and that we could benefit very quickly from greater partnerships with the world's management scientists, who largely live in academically in business schools, and create greater partnerships. Here at Berkeley, I've been saying the same thing with respect to the folks who do operations research, the folks who figure out how to best optimize Federal Express's delivery routes and things like that. Those engineers also have great relevance for our areas of work, and I think we would benefit a lot from stronger collaborations.
Alison, you've been really patient.
If I just may follow up on it, the ability to deliver goods in sub-Saharan Africa, Asia, when we talk about essential drugs, commodities, is really essential. So figuring out how could they do it as efficiently as delivering a bottle of Coke, or here in the US and Europe, Fed Express, is really an important question to address, and we still haven't figured it out. So a lot of room for research there. But I noticed that Alison
she had her hand up for a while.
Yes. So over
Alison,
to you.
please, your turn.
Head nodding.
Yeah.
That's fine. I just wanted to keep it up so you knew I had something, a thought I'd like to share. Is I really appreciate this talk about process and what that does, and the process, are those processes sustainable? And that takes us to, you know, ongoing research and ongoing sharing. And I think a big part of this, one thing we're not talking about, is who is our audience? I mean, when we are producing this evidence and building knowledge and strengthening processes and learning, who are we learning for? And are we building those feedback communications into that research? I mean, are we putting it, what is the purpose? And are those people benefiting? And how can they use it? And then how can they, once they get it and start to use it, how will it continue to grow? And I think that those audiences are diverse, and particularly with Weiher's work, I mean, they're, you know, we have to make sure that that everyone gets that knowledge in a way that they can understand it and use it, and then share it and build on it. And I think that's something that needs to be built into those networks and town and gown partnerships. So I'd love to hear about those thoughts. Thank you.
Yeah, I'll ask two people from town, Esteban and Cisse. You give us examples where you saw success. We want to be positive about our conversation today. Were there examples where you saw that being successful and helpful to you? We can start with whomever wants to volunteer.
I can go. This is a very good question. And we, in fact, had the experience with URC of implementing RCT, also with the local university, with Los Andes here in Colombia. And something that you mentioned at the beginning was the need to be rigorous in the approach. I think we benefit in several ways. The first way, we, as it was also mentioned, we, as implementers, we don't have that clarity on how rigorous it has to be to produce knowledge from a research, from an applied research, and both participating in the learning collaborative and also having the support of a local university helped us maintain that rigorous approach to collect the information and analyze it, being analyzed by a third party, a recognized third party, and done it very objectively. We also had some hypotheses that were changing through the applied research. For example, we thought the use of technology was a useful resource during COVID, and it was in the majority of the context. But in the very hostile context where we were providing our services, where we have connectivity issues, where we have privacy issues, where we have survivors of GBV that had no confidentiality in their households or examples as such, we found it very difficult to rely on technology, and the context and gave us the experience of with the results of the project interpreted that it was for our context specifically needed the in-person services, and digital or virtual services, remote services were not as effective as we thought. We think that this partnership between implementing organizations and academic institutions is very useful. We can provide practice and we can provide the experience, and they can help us interpret what is going on, match that with the theory, and also help us build training processes or development of capacity that is custom to our needs. We can't have long trainings, we can't adjust the schedules because services are provided every day to have weeks of training or months of training, and we need the people that get some space to use that attention very briefly and to maximize our interactions with them. So I think that in terms of the best practices that we can document, that we can develop through research and through the rigorous approach of our academic partners are of benefit for our programs, and keeping that knowledge in a way that we can share it among the globe and among the different international initiatives, because I think that this learning collaborative and the initiative the URC had of getting many implementing partners together and share those best practices and those challenges help us learn from other contexts.
I think this is a very fresh and important perspective. Bravo. And so important that we don't have to stereotype the roles, right? And you're speaking truths. Sisay, give us your perspective on what you believe the academic institutions can do to produce the graduate that can be most helpful to you in the field. Where do you see areas for improvement?
Sure. So right now we are working with the University of North Carolina to conduct a study on knowledge, attitude, and practices for population taking care of the under 5 population in terms of like improving hygiene, sanitation, and healthcare provision for the under 5 community, for the under 5 population. So there are students that are coming from that school that are working with the professors at University of Northern Carolina. So the students coming there and experiencing in person when they collect data, when they have that interaction with the community, it's in Niger, the project is in Niger. So when they have that first-hand experience of working with the community, collecting data, see how the healthcare system works, I think that is something that they can apply to their careers if they are going to be public health practitioners. So, exposing your students to such kind of practical experiences, I think can help them a lot. But also, focusing like the researches that they do, like instead of like making it more like scientific, just try to make it like more something like case studies or like something that's practical, like take the case of a country and analyze a project, or just like develop something that can be applied in the real world. I think something like that can help. I don't know if that makes sense to you.
Yeah, absolutely. You're emphasizing the field experience as a very important component of building skills.
Can I throw out a challenge? When we are saying we need more emphasis on process, are researchers and is our training really geared towards enabling students to understand and to learn about processes is our bias and our comfort level not much more geared towards evaluating impact and outcomes. And so I'm not sure that the training is well aligned with focusing on process instead of outcomes. And secondly, in order to understand process, it may be very hard to do if you swoop in from the outside. You have a few weeks to try and understand context and processes. That doesn't give you really enough time. And if you don't have that background, you will have a very hard time understanding processes and the difficulties. For example, we work in Mali. Working with communities is not easy. You need to understand the local dynamics. And most external researchers will not be able to grasp it in a short amount of time. So let me challenge you on that, because I'm not sure that our students are ready to evaluate processes. I'm exaggerating a little bit, but that's my whole point.
Yeah, I mean, they may not be ready for it, but I think the point that he was trying to make is that maybe they can be informed of the complexity of it and the difficulty of it, so that they don't approach these topics naively. And there's a lot to be learned from people in the field telling you why you can't do it this way. But you have to, I think what we don't teach our students enough maybe is listening skills or observational skills. Rohit, you have your hand.
I don't know from our panel and from the audience. I mean, what's your experience there? I would be interested, because I think it's absolutely true, but it's also, it turns out, I think, really being difficult. One of our most recent activities uses a sandbox approach. I don't know whether people are familiar with it, but where you really try out different approaches, and you need to look at process, what works, what doesn't work, why does it work. So that's an interesting approach. I don't know how many of our students would be familiar even with that concept. Rohit, you have your hand up.
Yeah, no, thank you. That the point that you make is really important. And I wanted to go back to what Steph said about this not just being about public health faculty, but being able to bring in the tools from management science and improvement. So my previous, before I joined the University of Cincinnati, I actually was at the University of North Carolina in the School of Public Health. And we had put together here the MPH program, Implementation Science, where quality improvement was one of the core courses along with implementation science. So the students actually learned to do process mapping. They had a project that they worked on either domestically or globally in partnership with organizations, helping, where one of the key activities was to begin to think about understanding how to map processes associated with service delivery. The second point, and of course, as you said, that is still kind of theoretical in the sense that you really do need some deep contextual knowledge in order to be able to understand the nuances of processes in various settings. So what we have done, I actually just returned from Ghana 2 days ago, and we had a group of I still have PhD students at the University of North Carolina that I took with me to Ghana, and we had a 2-day process mapping exercise where we got together the midwives. This was in the context of maternal child health in tertiary hospitals. So we brought together midwives, nurses, doctors, community members, parents from across the entire continuum of care for mothers and babies. And we did a 2-day process mapping exercise where essentially all that the students did was to watch, listen, and ask questions. And in that way, they kind of, by the time that the 2 days were done, the walls of the room were plastered with big sheets with the entire process laid out. And it really helped. And then there was a question and answer session where the students were beginning to ask questions about the process itself, and that allowed them, because the students are involved in a large scale evaluation of this program, and they needed to understand the process. And that was a experiential exercise that helped them to understand the process. Whether it's scalable or not is a different question, but we've been trying to immerse our students in understanding processes that are actually kind of constructed by the local people so that they can get a little bit of sense of the nuance as well.
Nice example. Thank you. Excellent.
Yeah, very good example. I think also there's a question of priorities. I think that many people like myself come into the field with their own priorities in terms of what they would like to study or how they would like to study it. And I would like to say that I myself was transformed as a researcher by people in the field telling me that this is not the right priority or this is not an important priority for them. The question becomes, finding funding to issues that are important to people in the field so that you can be loyal to their needs. At the same time, the question becomes that we as academics, we come into this arena with an underlying interest of forwarding our own academic careers. And there are certain parameters of what will be a good research project, what is publishable, and what would make you, what would be valued by your academic partners. And that is always a challenge. And Steph was a dean, and he knows not all currencies are sometimes transferable. So you can't change yen into dollars. Sometimes there is a problem there. And we as academics need to also, in the field of global health, perhaps grow up and have a better understanding. There may be a question on the, just as agree, we need to teach complexity, situation analysis, stakeholder engagement, and sustainable communities. More questions that you may have?
Ayman, we are at about an hour now. I don't know whether people still have time.
We have an hour and a half, actually. We're destined till 6, but we can stop at any time after an hour. So we can make final statements. I'm very comfortable asking Alison to give us her perspective on what she's heard today and what she'd like to leave us with, and then we can go around the table.
Thank you. It's been lovely being on this panel and hearing the different perspectives. I'm looking forward to reading your paper, Dr. Ramaswamy. And I think that we're all on the same page, that the research is an essential arm of the implementation. And how does that look? And how can we best bring that to contextualize it, to bring it to those that are working in the field, have the skills to deliver it, and that in some way they're consistent. I really heard that they take pieces of what they learn all over the place, and how can we not create one, contextualize it, but still make some kind of standard. I really appreciated what Troy said about, I also come from the quality improvement and behavioral science side of research and implementation science, and that does contextualize it, and it makes it accessible to more, and it also establishes processes for that sustainability. So I think that partnership and ownership and shared ownership is where we're going, and I think all of us have ideas and experience to bring that to bear. Thank you.
Thank you. Esteban, your thoughts?
Yes, I agree with Alison. I think that we're all on the same page. I just wanted to emphasize on something that was going through my mind in regards to that practice and the development of knowledge. I think that one of the points that I also wanted to share is the need for, and it was mentioned before, the need for continued and more closed supervision. In the field of mental health, for example, we don't have enough supervisors for our service providers, for our professionals. And I think that the academia has that practice well established in the psychology or behavioral sciences faculties, and they do this with rigorous approaches that could help that connection between the practice, what is being done in reality in the field, but also what are the gaps to do it better, and also link the training modules or the training approaches, courses with the needs of the field. So I wanted to also mention that, as well as the needs for emotional support for providers in the field. I think that we have discovered on our practice that working with violence, working with humanitarian needs creates a baggage, an emotional baggage on our employers that we have to treat, and we have to institutionalize policies, procedures for staff care, but also in the day-to-day practice, if they can have that that protection awareness of themselves, putting them in this environment and with these needs, and academia can also help or support those processes of building knowledge of what are those best practices in that field. So I wanted to mention that, and I think that all that he has been shared here has been very interesting and of much use. Thank you.
Thank you, Esteban. Cecile, how about you giving us your final comments?
Sure. Yeah. Thank you so much for the opportunity. I really enjoyed all the conversation. I think the academic community, the research community can help us a lot to be more effective and more efficient in terms of, producing applicable knowledge products. And well, not only that, but technology, for example, how can we use technology to be more effective in implementing public health programs anywhere, especially in fragile settings? But not only that, how can we also use technology for day-to-day project implementation so that, we can have, because the people in the field, they have a lot to accomplish, and sometimes, they might be, they might have mental health issues because some of them are working in a very insecure context. So how can we help them to be more effective, more efficient, and stay healthy and productive so that, they can help others? So I would like to speak in terms of like the, I would like to emphasize on the technology side, because technology is now, it's almost everywhere. Yeah, people have access to mobile health phones, but they may not have access to maternal health care. So how can we leverage that technology for the better of humanity? How can we sustainably integrate that technology into health systems, for example, at a scale that can help to improve health systems resilience? We were able to use some technological products during COVID-19, and how can we improve that further? I think that is something that can be researched a lot. And how can we use these technological products to improve supply chain, for example, to track medical products, vaccines, immunization campaigns, improve, tracking beneficiaries. We really have a problem on that side. Like sometimes double counting happens. So how can we be able to track beneficiaries, like so that we can have like more quality, concise, and precise data? And how can we also create partnership with the private sector? Because the private healthcare system in countries like in continents in Africa, in Asia, it's now booming. So how can the private sector, how can it also work with the public sector, and how can the NGOs be, can play the role that can bring everybody together? Thank you.
Thank you very much, Justin. Troy, would you like to add something to what our colleagues have mentioned so far from a funding agency's perspective, and what you'd like to see?
Well, it's been a very good discussion, and I see a number of themes coming forward. I struggle people have mentioned students and mentors and supervisors. And in fact, I see and hope that some of that is being reconfigured in real time as we go forward because of COVID and because of these other things. Because if we're really interested in sustainability, we're interested in localizing and being focused on country context and what makes the most sense at that level, we've got to reconfigure. And it's not just USAID, it is academia and the way that academia works, not just within this country, but around the world. So I'll leave it at that. Yeah,
we'll try to be better. It's very difficult. We're really set in our ways. It's not easy.
Well, it's the collective
I've been in academia all my life, but I see what you're saying and I know what you're talking about. I'm a true believer that there needs to be a new look. I will end with the academics, but I wanted Eckhart to give his perspective before I move to Rohit and then end with Steph.
Yeah, we have another question, and that's the creative tension between the time it takes to implement an intervention and the time that's available to evaluate it, which may not be in harmony. It's a question from Rosie Goran, and it's an excellent question. And I think it's something we are struggling with all the time. It's not going to go away. We have to make the best of it. I just wanted to follow up on Troy's point about the pandemic. COVID has not only created new opportunities and need for research, but it certainly impacts also the research we were doing, and the two studies that I had mentioned, both were affected by it. And that means three things. We need to be flexible and we need to adapt. Our partners were able to adjust to the pandemic. They were still able to interact with providers to complete the study, but it took longer. So we need to be prepared that we extend the timeline. Instead of a year, it took a year and a quarter, not too bad. But that goes also, it needs some flexibility in terms of budget. Those things come at a cost. There's no way around it. I mean, the physical distancing, the inability to visit providers at the time scheduled because of the pandemic, because there are local laws in effect that prohibit people from interacting. The bottom line is that not only the researchers, but also the providers, they did their best to continue in providing services. We saw that over and over again. I mean, it's just the dedication that's out in the field is enormous among the researchers and the service providers. We couldn't do anything without them. So I just wanted to give a shout out there.
Thank you very much, Eckhart. Rohit, your perspectives before we close the session, and please, Steph, prepare your last comments as well.
Yeah, thank you, Iman, for inviting me to this session. This has really been a very rich discussion, and I'm delighted to be part of it. I wanted to actually just start very quickly with answering Rosie's question as well about the implementation evaluation. And that is exactly right. If we thought about evaluation of implementation processes as only being part of the kind of academic evaluation, we are not going to be able to capture the factors associated with sustainment that were mentioned. We're not going to be able to capture scale up, which typically happens after the initial funding has gone. And so what we've been trying to do in thinking about evaluation methodology is that there is the traditional outcome evaluation that perhaps an external evaluator does, but we've built into our project and our implementation projects capacity for ongoing implementation evaluation. So for example, the work that I'm talking about in Ghana, we've trained the midwives to be able to do monitoring of the implementation of the process. And that monitoring system is something that we put in place that gets spread across the different facilities to which the implementation gets scaled. And so they have the capacity to do monitoring and evaluation on an ongoing basis, which is separate from the grant-funded evaluation. So that's one way in which we can maintain the evaluation, the implementation process. In terms of closing remarks, I wanted to reinforce what Troy said about half an hour or so ago, which is about global health decolonization. We have talked a lot about what Western universities could do. We've talked a lot about sending students from here to get acclimated in low-income settings. But ultimately, the last time that several of us met was in the global conference for, I think it was called the Global Conference for Implementation Science in Dhaka. And
that was great.
Yeah, and that was one of the first conferences that was, or implementation science conferences that was completely organized by and in a low-income setting. We have since completed 3 years later a evaluation of the participants of the conference. That is a paper that's currently under review and hopefully will get published in a month or so. And the one point that was made by all of the participants, apart from really appreciating the fact that this was a conference by researchers and practitioners in low-income settings, was the need to be able to decentralize implementation science, to be able to take the locus of implementation science research and knowledge production away from Western universities and really distribute it across the world, because for some of the contextual reasons we mentioned, but also it's not so much about low-income countries using methods that have been developed in the West, but actually being leaders in creating methods that might be more relevant to them as well. So I wanted to leave us with, while we as faculty members in Western institutions certainly have a role to play in advancing the field, we must do so with humility, and we must do so with an ongoing recognition that ultimately our goal is to be able to decentralize this work that we're doing, so that there are other pockets of where knowledge gets produced as well. Thank you.
Thank you so much for that. And Steph, we keep the best for last. So please, your final closing remarks.
I wish that were true. Thank you, though. I was
believe me, it's true.
I was sitting here listening to all of you, and I'm thinking about the fact that we're 2 years into the pandemic, and I happen to be taking this call from Miami Beach, of all places, where we're going to go into curfew tonight at midnight because people are so misbehaving. And I thought to myself, what is the silver lining I see out of this process that we've been through for the last 2 years, the millions of people who have died? And I think that there are a number of silver linings. One is that my area of public health is health policy and management. So I've spent decades saying to people in the countries in which I've been living and working that there may be some useful academic institutions in the United States, but please don't look at the healthcare system in the United States, because no country does a worse job at translating investment in health into actual health. Nowhere is more inefficient. But there's always been this sometimes false acknowledgement of the need for South-North learning as well as North-South learning. But boy, did the COVID pandemic spank the North, right? I live in California, which is maybe 3 times per capita as rich as South Korea. And we were in a country that was competing for the worst containment of COVID and for the greatest per capita mortality rates and speed of transmission, while South Korea lived life pretty much as normal for the last 2 years. So, and a real lesson in humility, which is an important step toward treating each others as collaborators and peers. And why is that relevant to implementation science? It's because we had lots of smart people in the CDC, and the world recognizes how many smart people are in the CDC with respect to infectious diseases, but that doesn't translate into effective implementation. And so many low and middle income countries did a better job in implementation. In some cases, because of previous experience, having an experience with SARS and MERS, those countries did a lot better in response to this pandemic. But I think the other parts of silver lining is that what we're doing right now the kind of online collaboration that we can do, we didn't used to do in the same way before. And even more importantly, from my perspective, we used to poo-poo and think that it was really third-class citizen, the idea of doing online education. And because of the pandemic, the best universities in the world made their entire offerings virtual. And many of us, in my case, 2 of my classes have remained online because if you're teaching global health and want to involve people from countries around the world in your classes, it's better online than it is in person with a recorded message. So our ability, in addition to that, I'm a member of the class that jumped on airplanes all the time and went to country to work because that was seen as a necessary prerequisite. This week, I was doing quality assurance with my colleagues in Rwanda who were in the field collecting the results of a survey, and we were doing it virtually in real time. So I actually am encouraged that implementation science, collaboration, and working together and learning in all directions, north, south, south, north, south, south, north, north, can be in some ways improved by what we've been through. And as I think was said at the very beginning, universities like funding agencies change slowly. Sometimes you need a real kick in the behind. And this pandemic, I think, gave us a kick in the behind. So I'm going to choose to be optimistic, even though I'm in Miami Beach. And my wife and I are the only people with masks for multiple square miles. And think that there's good to come from the collaborations that we can establish and the kinds of collaboratives that we can form in the future, and that implementing will be better as a result. Thank you all so much.
Steph, thank you so much. And what a great panel. I'm honored, and with my dear co-chair Eckhart, I'm honored to have been included on this panel. Our audience has sent a lot of compliments to you all. I'm the one that's reading them, but they were telling me what a great presentation this was, and a great day as well. I think Emily will thank everybody for the entire day. A very, very hearty thank you to you all. For those that are old friends, thank you, and great to meet you online. And for the new friends, what a pleasure to have met you today. Thank you so much.
Thank you, everyone. I'm Emily Pekka from URC, and I'd like to send a special thanks to Steph as our Implementation Science Collaborative co-convener, all of the co-chairs in particular for this session. And we'd like to thank Troy and USAID through the HEARD project for your very generous support. And we look forward to engaging all of you in further discussions as part of our Implementation Science Collaborative. So be well, and thank you so much.
Thank you, Emily. Nice to see you.